Good morning, ladies and gentlemen, distinguished speakers and delegates, and esteemed colleagues. Welcome to this special gathering on World Cancer Day. A warm welcome to ICON 2024, the International Conference on Advances in Oncology, hosted by the prestigious Dr. K.M. Cherian Institute of Medical Sciences, Chenganur. We are the hosts for today, myself, Dr. Pooja Raghunath, consultant microbiologist,
and myself, Dr. Arun Thomas, consultant neonatologist. Today we come together to raise awareness and to discuss strategies in the fight against cancer. In the next few hours, we'll be privileged to hear from experts who have dedicated their lives for the advancement of research, improvement of patient care, and promoting prevention of cancer. Before we dive into the wealth of knowledge awaiting us, we have the pleasure of hearing from some introductory remarks from our own consultant surgical oncologist, Dr. John Thomas. Over to you, John.
Good morning, ladies and gentlemen. It's with immense pleasure and profound gratitude that I extend a very warm welcome to each and every one of you gathered here today on this World Cancer Day for the auspicious occasion of the inauguration of our oncology department. This momentous event marks a significant milestone in our journey towards advancing healthcare and bolstering our commitment to combat cancer. Named after the illustrious Dr. K.M. Cherian, a pioneer in the field of cardiac surgery, this hospital stands as a testament for his unwavering commitment to advancing medical sciences and alleviating human sufferings. Dr. Cherian's legacy of compassion, expertise, and groundbreaking achievements continue to inspire us all as we embark on this new chapter. The establishment of this department symbolizes our unwavering dedication to provide comprehensive and state-of-the-art care to those battling cancer within our community and beyond. Cancer, as we all know, is not merely a disease, but a formidable adversary that affects millions worldwide. However, through collective effort, determination, and innovation, we stand poised to make a difference in the lives of those affected by it. At our oncology department, we have assembled a comprehensive suite of facilities, equipments, and services, each meticulously designed to provide the highest standard of care for our patients. Allow me to walk through some of the key components of our department. We are equipped with state-of-the-art technologies and treatment modalities, including advanced chemotherapeutic regimens, targeted therapies, immunotherapeutic agents, and precision medicine approaches. These therapies are tailored to each patient's unique cancer profile, maximizing efficacy while minimizing side effects. Our surgical oncology team comprises of elite surgeons specializing in complex cancer surgeries. Utilizing advanced techniques and minimally invasive approaches, they perform intricate procedures with precision and expertise, striving to achieve optimal outcome for our patients. Our forthcoming radiation oncology department boasts the latest in radiation therapy, including IMRT, stereotactic radiosurgery, and brachytherapy. Our skilled team ensures precise targeting of tumors while sparing normal, healthy tissue. With advanced diagnostic imaging modalities, including CT, MRI, and the proposed PET scan and molecular imaging, our department facilitates timely and accurate cancer staging and treatment planning. We believe in a collaborative approach to cancer care, with tumor board meetings bringing together experts from various specialties, including medical oncology, radiation oncology, surgical oncology, pathology, radiology, and all other departments to discuss each patient's case and to develop individualized treatment plans. Our commitment to holistic patient care extends beyond medical treatment. We offer a range of supportive services, including palliative care, pain management, nutritional counseling, and psychological support. Our goal is to address the physical, emotional, and psychosocial needs of our patient and their families throughout their cancer journey. We are committed to raising awareness about cancer prevention, early detection, and treatment options within our community. Through educational workshops, outreach programs, and public health initiatives, we strive to empower our individuals with knowledge and resources, making informed decisions about their health. Our oncology department is more than just a facility. It's a beacon of hope, compassion, and excellence in cancer care. With a dedicated team of healthcare professionals, state-of-the-art technology, and a patient-centered approach, we are steadfast in our mission to combat cancer and improve the lives of those affected by this disease. As we embark on this journey, I extend my heartfelt gratitude to all those who have contributed to the establishment of this institution, the visionary leadership of our chairman, Mr. P.M. Sebastian, Vice Chairman, Mr. Sibin Sebastian, our Director, Padma Shri Dr. K.M. Cherian, Managing Director, Reverend Father Dr. Alexander Kudarathil, Advisory Board Chairman, Oncology Center, Dr. M.V. Pilesa, Medical Director, Oncology Center, Dr. Sara Ishu Madam, all the board members, all healthcare professionals, the supporting staff, the community, and above all, the patients and their families who inspire us to strive for excellence every day. It's with great pleasure and anticipation that we are here today to witness the inauguration of our department by none other than Dr. C.S. Pramesh Sir, Director of Tata Memorial Hospital, Mumbai, a distinguished leader in the field of oncology and an inspiration to all of us. Following the inauguration, we have an exciting CME session planned featuring esteemed speakers, including Pramesh Sir himself, along with Padma Shri Dr. M.R. Rajagopal Sir, Chairman of Pallium India and Director of Trivandrum Institute of Palliative Sciences, along with Padma Bhushan Dr. Shivakumar Sarin Sir, Director of Institute of Liver and Biliary Sciences, New Delhi, Dr. M.V. Pilesa, and Dr. Sara Ishu Madam, who will share their insights and expertise on various aspects of oncology. In conclusion, I invite each and every one of you to join us in celebrating this momentous occasion and to join hands as we work together for our shared vision of a healthier, happier future for all. Thank you.
Thank you, Dr. John. Now let's move on to the much awaited inaugural ceremony. To grace this auspicious event, we have with us Dr. C.S. Pramesh, Director of Tata Memorial Hospital and Professor and Head of Thoracic Surgery at the Tata Memorial Center, Mumbai. Dr. M.V. Pillai, Member of the Governing Council of Kerala's RCC and Chairman of Advisory Board, Oncology Center, K.M. Cherian Institute of Medical Sciences, Chenganur. Padma Shri Dr. M.R. Rajagopal, Chairman of Pallium India and Director of Trivandrum Institute of Palliative Sciences, Trivandrum. Dr. Sara J. Isho, Medical Director, Oncology Center, K.M. Cherian Hospital, Chenganur. And our patrons, Sri Sibin Sebastian, Vice Chairman, KMC Hospital, and Reverend Father Dr. Alexander Kudarathil, Managing Director, KMC Hospital. Request all dignitaries to please take their seat on the dais.
Dr. K.M. Cherian Institute of Medical Sciences is a well-equipped super specialty hospital located at the heart of Chenganur in Alleppey district of Kerala, initiated by a group of professionals and entrepreneurs under the chairmanship of international industrialist and healthcare management expert Sri P.M. Sebastian and clinical leadership of world-renowned cardiac surgeon Padma Shri Dr. K.M. Cherian and directorship of Reverend Dr. Father Alexander Kudarathil. This institute is fanned out over an area of 3.5 lakh square feet with 300 plus beds, 100 plus ICUs, a multifunctional cath lab, and a fully fledged emergency department with level 1 trauma care. We have more than 32 departments, including specialities and super specialities with state-of-art care.
I request Reverend Father Dr. Alexander Kudarathil.
Let's seek God's blessings before we move on. Request everyone to rise for the prayer. seated.
I request Reverend Father Dr. Alexander Kodarathil, Managing Director, KM Cherian Hospital, to deliver the welcome address. Reverend Father Dr. Alexander Kodarathil started his career as a secretary to His Holiness Moran Mar Basilios Marthoma Matthews II, Supreme Head of the Indian Orthodox Church, in 1992. From 1999 to 2011, his tenure as the Chief Executive Officer of St. Gregorius Medical Mission Hospital, International Cancer Center, College of Nursing, School of Nursing and College of Social Science, College of Medical Lab Technology, Director of St. Gregorius De-Addiction Center, made him one of the most respected administrators in Kerala healthcare sector. Since 2015, he is the Managing Director of KM Cherian Institute of Medical Sciences, Chenganur, and Chief Counselor and Therapist of the De-Addiction Center. Currently, he is the Joint Director of TRADA, a Center for Alcoholic and Drug Addiction Treatment by the Ecumenical Churches. Also, he is the member of the Pradhan Mantri Jan Vikas Karyakram, Patnamthitta District Committee. He is also the winner of the prestigious award by the World Malayali Council. He is the author of Lahari Innu Agale, a book on de-addiction and substance abuse, which was well received by the Malayali community across the globe. There are many more to his credit. Over to you, Father.
Most respected Dr. C.S. Pramesh, Director, Tata Memorial Hospital, Mumbai. Dr. M.R. Rajagopal, Chairman, Pallium India and Director, Trivandrum Institute of Palliative Sciences. Dr. Shivkumar Sarin, Director, Institute of Liver and Biliary Science, New Delhi. Sri Sivin Sebastian, Vice Chairman, Dr. Kemjara Institute of Medical Sciences. Dr. M.E. Pillai, Advisory Board Chairman, Oncologist and Dr. Kemjara Institute of Medical Science. Dr. Sara Isho, Medical Director, Dr. Kemjara Institute of Medical Science. And Mrs. Celine Sebastian, Jidin Kumar, our Board of Directors, and all the distinguished doctors present here from various parts of the country. The eminent researchers present here to enlighten us in ICON 2024, the International Conference on Advanced Oncology, and for the inauguration of our most ambitious division, Oncology. The gifted doctors across India, our doctors, my distinguished guests, the fellow colleagues of this institution, all other distinguished, and our staff and dear ones. Dr. Kemjara Institute of Medical Science is a well-equipped super specialty hospital at Chenganur, Kerala, initiated by a group of entrepreneurs and also a chairmanship of the International Industrials and Healthcare Management expert, Sri P.M. Sebastian, and with the clinical leadership of Dr. K.M. Cherian, the world-renowned cardiac surgeon Padma Shri. He is the head of the cardiology center also. Today is a special day for Dr. K.M. Cherian Institute of Medical Science, as we are inaugurating our oncology division and the international conference called Advanced ICON 2024. Today you know that the World Oncology Day, and I extend my big salute to the health workers who are fighting for against this cancer and praying for the those affected. We wish all the oncology doctors, staff and health workers here and all over the world. Under the great vision of our chairman, Sri P.M. Sebastian, we are always focusing on innovation and providing world-class treatment at affordable rates. Today, we have legendary oncologists and also the most modern technology at our division with all his great support only. We are really delighted and inspired by the presence of Dr. C.S. Pramesh, a great leader guiding the most prestigious Tata Memorial Hospital in Mumbai, keeping aside all his busy schedule. He is the director of Tata Memorial Hospital and the professor and head of the thoracic surgery at the Tata Memorial Center, Mumbai. He is the convener of National Cancer Grid, a large network of 300 plus cancer centers in India. He serves on the advisory board of several national and international research organizations and granting agencies, including ASCO, ESMO, and the UACC. Professor Pramesh has strong interest in clinical trial designs, surgical trials, comparative effectiveness research, promoting collaboration research, health service research, and cancer policy. Sir, I have visited the Tata Memorial Hospital during the year 2007 along with Mr. John Jandy. He is the CEO of the Apollo Hospital. And at that first time I visited the tomotherapy unit there. And I can understand and took the knowledge and information for the management system of the entire hospital. I proudly extend our delightful and welcome to you, Doctor. Thanks. I welcome the Vice Chairman of KMCH Hospital, Sri Sibin Sebastian, who is delivering the presidential address. Sri Sibin Sebastian shares the responsibilities and the development activities with the most modern concept and models to attain our common vision of health solution at world-class level. He is the Vice Chairman of Bosco Group and the Vice Chairman of Wellcare Hospital, Vaitila. On behalf of this gathering, I welcome Mr. Sibin Sebastian on this occasion. I am proud to have Padma Shri Dr. M.R. Rajagopal, Chairman, Pallium India and Director of Trivandrum Institute of Palliative Science, to deliver the scientific session in this international conference on advanced oncology-icon 2024. Popularly known as the father of palliative care in India, a legendary humanitarian healer and thought leader. He has received numerous awards and honors worldwide in recognition of his pioneering work in promoting palliative care and relief from suffering across India. These include the Padma Shri by the Government of India in 2018 and a nomination for the Nobel Peace Prize. I would like to bring the memories to 2009 when I started Palliative Care Center in Parimala. You have given all the support and guidance for starting that Palliative Center and given the training for the staff in Pallium India Trivandrum. On behalf of the gathering and the hospital, I welcome you, sir. I extend our warm welcome to Padma Bhushan Sri Shivakumar Saran, Director, Institute of Liver and Biliary Science, New Delhi. He has significantly contributed to the development of several treatment protocols for liver disease. He has worked on gastric varices and their classification base is named as Sarin's classification of gastric varices. 17 major treatment protocols have been credited to him, including 5 major Asian Pacific treatment guidelines in liver disease. His work has assisted in the understanding of chronic HBV infection, liver cancer, and B and C variants of hepatitis. Dr. Sarin is one of the initiators of the hepatitis B vaccination program in India and one of the organizers of the Yellow Ribbon campaign, an annual program started in 1998. It was under his chairmanship that the Medical Council of India introduced the Vision 2015 document which proposed guidelines for regularization medical education in India. I have visited this ILBS during the year 2020. At that time, I have got the chance to meet all the heads of the liver and digestive science hospital heads, and came to know that the liver and biliary science is the first center in India. From that inspiration, we have planned to here to start the best Treatment Center for Liver and Digestive in Dr. K.M. Jarian Institute of Medical Science. Even though his physical presence is not here, but his active participation through online class, I welcome on behalf of you, Dr. Serin, in this solemn function. Here we have the world-renowned oncologist Dr. M.B. Pillai, Advisory Board Chairman, Oncology Center at Dr. K.M. Jarian Institute of Medical Science. The Clinical Professor of Oncology in Thomas Jefferson University of Philadelphia, USA, President of International Network of Cancer Treatment and Research, a doctor among word of letters, and a literarian among doctors. That is, we have seen Dr. M.B. Pillai. Sir, you are the mentor and the driving force for this Institute of Cancer Center. On behalf of us, I welcome you, sir. I welcome Dr. Sarah Isho, Medical Director, Oncology Center at Dr. K.M. Jarian Institute of Medical Science. Dr. Sarah Isho is a specialist in hematology and medical oncology. She completed her MBBS from Kottayam Medical College. She completed her post-graduation training in USA and fellowship in hematology and medical oncology at New York University, USA. She founded Ocean Hematology and Oncology 2006, a Center for Cancer and Blood Disorders in New Jersey, USA. Her practice got affiliated with the Robert Wood Johnson Medical Center and Cancer Institute of New Jersey, USA in 2018. Dr. Sarah is a well-rounded hematologist and oncologist with a vast experience in treating different types of cancer and blood disorders. She also has special interest in creating awareness in the public about cancer prevention and screening. A warm welcome, Dr. Sarah Isho. I welcome the reputed scholarly delegates who have joined us from far corners of the world with new ideas to address the issues connected with the oncology. Warm welcome to you all. Especially, I welcome Mrs. Celine Sebastian, our Board of Directors, and wife of our beloved Chairman, Sri P.M. Sebastian, and also Mr. Jidin Kumar, our Board of Directors. On behalf of our delegates and participants, and I welcome you all. I once again welcome all my hard-working colleagues, medical and non-medical staff, guests, friends, and well-wishers to ICON 2024 and for the inauguration of the Oncology Division. Let the scientific sessions generate new solutions to address the health concerns in our world. The doors of KMC Hospital will be open to such positive thoughts always. Thank you very much.
Thank you, Father.
Next, let's invite our dearest Sri Sibin Sebastian, Vice Chairman, KMC Hospital, for the Presidential Address. Mr. Sibin Sebastian is also the Administrative Director of Bosco Group, founded in the year 1987 by Mr. P.M. Sebastian. Over to you, sir.
A very good morning to everybody. My name is Sibin Sebastian. I'm the Vice Chairman for KMC Hospital and the Managing Director for Bosco Group, which is based out of UAE, Oman, and India. I am honored to address various distinguished guests who made it here on a beautiful Sunday morning, and especially our key guest, Dr. C.S. Pramesh, Director of Tata Memorial Hospital, Mumbai, Padma Shri Dr. M.R. Rajagopal, Chairman Pallium India and Director of Trivandrum Institute of Palliative Sciences, Dr. Shiv Kumar Saran, Director of Institute of Liver and Biliary Sciences, New Delhi, He couldn't be with us today, but I understand he's viewing us online. Dr. M.V. Pillai, Advisory Board Chairman, Oncology Center at KMC Hospital. Dr. Sara Isho, Medical Director, Oncology Center at KMC Hospital. Reverend Father Dr. Alexander Kudarathal, Managing Director of KMC Hospital. Our board members, Celine Sebastian and Jitin Kumar as well. Other distinguished guests, ladies and gentlemen. Today marks a special day for Dr. K.M. Cherian Institute of Medical Sciences, as we are inaugurating our Oncology Division and the International Conferences on Advances in Oncology, ICON 2024. KMC first opened its door in March 2021, and within a short span of time, it was able to become one of the most renowned health centers in our region. Today we boast more than 34 departments, 100 plus doctors, and more than 1,200 staff. Today we are very proud to inaugurate our Oncology Division under the great vision of our Chairman Shri P.M. Sebastian. Under his guidance, we are well equipped with world-renowned oncologists, compassionate staff, most advanced equipments, and all the modern amenities. Our Advanced Oncology Center caters to the needs of one of the most common diseases that we are facing globally today, cancer. The patients that live in a radius of 150 kilometers around Chenganur will be the ones to benefit the most, including a great NRI population as well. Our primary focus is on preventive oncology, which is a specialized discipline in oncology that focuses on key measures that prevent cancer development or delay the progression of malignant process of cancer cells. We have 3 stages. Primary prevention addresses the cause of cancer so that diseases do not occur. Secondary prevention identifies disease before the onset of symptoms and keeps it from becoming more extensive. Tertiary prevention reduces the complication and progression of diseases once it has become clinically apparent. Our health promotion programs aim to engage and empower individuals and communities to choose healthy behaviors and make changes that reduce the risk of developing chronic diseases and other morbidities. Timely treatment and access to affordable treatment centers plays a crucial role in cancer treatment. We would like to walk with them during this tedious journey as pillars of support, providing comfort, care, counseling, confidentiality, and expert medical care. We are delighted to have future research associations with Tata Memorial Hospital, Thomas Jefferson, Mayo Clinic, Institute of Liver and Biliary Sciences, and Pallium India. We have started off our journey to fulfill the aspirations of our nation. We are glad to join Heal in India and Heal by India projects of our Honorable Prime Minister Narendra Ji Modi. Let us all remember that we are all responsible to keep our nation healthy. With that, I conclude. Thank you very much and wish you all a blessed Sunday. Thank you.
Thank you, sir.
Now let's move on to the lamp lighting ceremony. Ladies and gentlemen, it is indeed an honor to invite Dr. C.S. Pramesh, Director, Tata Memorial Hospital, Mumbai, to light the lamp and inaugurate the Oncology Center, K.M. Cherian Hospital, Chenganur. Request all the other dignitaries to join in as well.
शास्त्रसुधा जलधे महितोपनिषत् कथितार्थनिधे हृदये कलये विमलं चरणं भव शङ्कर देशिकमे शरणम् करुणावरुणालय पालय मां भवसागर दुःखविदूनहृदम् रचयाखिल दर्शन तत्त्वविदं भव शङ्कर देशिकमे शरणम्
Before we move on to the inaugural address by Dr. Pramesh, we have an exciting news for you. We are thrilled to announce that our inaugural hospital newsletter, aptly named Hope, is ready for its grand debut. Join us as we unveil this beacon of information, inspiration, and connection, bringing you closer to the heart of our healthcare community. We are honored to invite on stage Dr. Devarajan, consultant cardiologist, KMC Hospital, to officially hand over the first print of Hope to Dr. Pramesh. Hope, standing for healthcare outreach, progress, and excellence, symbolizes our commitment to keeping you informed about the latest developments, medical advancements, and heartwarming stories within our hospital community. Thank you, Devarajan sir.
Now we move on to the inaugural address by Dr. C.S. Pramesh, followed by his talk on the National Cancer Grid, reducing disparities in cancer care. As we move forward with the program, we would like to kindly request a brief adjustment on the dais to accommodate some logistical requirements. It would be immensely helpful if the other dignitaries could step down from the dais. We would like to express our sincere gratitude for your esteemed presence and participation in the inaugural ceremony. Dr. C.S. Pramesh is the director of Tata Memorial Hospital and the professor and head. He's been serving on the UICC Board of Directors since 2020. He is the convener for the National Cancer Grid. The mandate of the National Cancer Grid is to provide uniform standards of cancer care across the country. Dr. Pramesh is highly committed to efforts towards reducing inequities in cancer care and making cancer treatment accessible to all geographic regions and strata of society. He is the recipient of the prestigious Rachel Perline Global Cancer Research Humanitarian Award from the National Cancer Institute, USA. He's a visiting professor of Davidson Division of Cancer Studies, King's College London, the Institute of Cancer Policy, King's Health Partners London, and the National Cancer Center Graduate School of Cancer Science and Policy, Korea. He serves on the advisory board of several national and international research organizations and granting agencies. He has more than 300 peer-reviewed journals, abstracts and book chapters on various topics, including thoracic oncology, clinical research methods, and translational research, cancer policies, and health disparities. He's keen on promoting training in clinical research methods and conducting several courses on clinical research methodology, biostatistics, and scientific writing. Over to you, sir.
Thank you. Thank you. Distinguished friends, it's indeed a great privilege and a pleasure to be part of this group on this very momentous occasion of the inauguration of the K.M. Cherian Institute of Medical Sciences Oncology Department. I must extend my deep sense of gratitude to Dr. Sarah Iso and Dr. M.V. Pillai, who invited me to be part of this right from its inception. And I can't think of a better way to spend today, which is the World Cancer Day, than in what seems to be the birth of an organization and an institution which has deep-rooted ethos of working towards empowering patients in their journey towards all of healthcare, including cancer as it stands today. Given the breadth of participation and the faculty and the strength of the expertise that is available here, I have no doubts that this will become one of the leading institutions for cancer care in this part of the world. Kerala has always been known for having stellar healthcare facilities, but given the terrain that Kerala has, you can never have enough. And that is the reason why another institution which is able to treat cancer in this part of the country is extremely important, because one of the most important determinants of outcomes for patients and what happens to them after a diagnosis of cancer is dependent on how far they live from an expert center. Much of what I speak later on in relation to the National Cancer Grid will deal with these problems of access, but I'm really very fortunate to be part of the birth of this department within this very prestigious institution. So over the next few minutes, what I hope to share with you are very random personal thoughts on how we should work towards reducing disparities in cancer care across India and, more importantly, across the world as well. Can I have the slides presented, please? So as I mentioned, disparities in cancer care are a reality. And the UICC theme of close the care gap, which has been in place for the last 3 years, is to do exactly with this. Recognizing the fact that there are inequalities in access to care, inequalities dependent on race, on geographic region, on socioeconomic status, and in gender, we need to work towards reducing these inequalities and reducing these disparities in what is something which is very basic, which is healthcare to all of us. So my journey on disparities started with this study of close to 75,000 patients who visited the Tata Memorial Hospital over a 6-month period. So what we did was to geotag them based on their location of residence. And for those of you who are not aware of where Tata Memorial Hospital is, it's in Mumbai, which is this black dot that you see here. So the density of patients that you see from the city of Mumbai and the state of Maharashtra is something that is very understandable. Only 13% of patients who visit our hospital come from the city of Mumbai. An additional 25% come from the rest of Maharashtra, which means that 38% of all patients who visit us at the Tata Memorial Hospital come from the state of Maharashtra. The more disturbing statistic is that 62% of our patients come from distances which are very far away. And you can see from this heat map the very disturbing concentration of patients in northern, eastern, and northeastern India. And just to give you context, yesterday I flew in from northeastern India, from a place called Dimapur in Nagaland. And it took me 18 hours traveling by flight to reach from Nagaland to Cochin. So just imagine the plight of a patient and the family members who have to travel from these long distances to cities like Mumbai, Delhi, Chennai, Bangalore to access basic cancer care. It's not just the time of travel, the expenses of living in a city like Mumbai is something that is probably evident to all of you. The result of all this was that many patients were unable to complete their treatment. Many people call this as a patient abandoning their treatment. I look at it a little differently. Patients don't abandon treatment. I think the healthcare system fails them in not offering care close to their homes, which is one of the reasons why we thought of something that need to be different. Right from our schooling, we have been taught about the importance of equality. I think this is something that is fundamentally, inherently fair and just in anybody's world. It's part of one's philosophy that you need to work towards equality. Equality, whether it is race, whether it is religion, whether it is socioeconomic status or gender. And unfortunately, what we see And just to emphasize the importance of equality, whichever democratic country that you look at, the constitution embodies equality as one of the most important tenets, and India is no exception. It is front and center in the preamble to the Constitution of India that we have to work and strive towards equality. And I look at equality not just as a privilege for individuals, but as something which should be a basic human right. But when we look around us, and you don't need to look very far, what we are faced with is the stark reality of inequality and disparities that we see everywhere in the world. It again is socioeconomic, religious, gender, you name it, and you are faced with inequalities all over the world. I'll take you through one example which illustrates, which is probably the easiest to understand when it comes to inequality. There is something called the World Inequality Report, which comes out every year. In the last World Inequality Report, what was identified was that when you look at income, and by income I mean regular income coming into individuals' homes, the top 10% of the world's rich owned or earned more than 50% of the world's income. The bottom 50% of the world's poor earned under 10% of the world's income. And if you think these differences are stark and need to be addressed, what is even worse is when you look at world wealth. The difference between income and wealth being that income is something that comes to you on a regular basis, wealth is what you own. And when you look at the assets that the world owns, you'll notice that the top 10% of the world's wealthy own over 3/4 of the world's wealth. And the bottom 50% of the world's poor, between them, own 2% of the world's wealth. So on one hand, you have a bunch of individuals who own 3/4 of the world's wealth, and on the other hand, you have more than 50%, more than half of the world's population having just 2% of the world's wealth. So clearly, we have a long, long way to go before we can claim that we are anywhere close to eliminating these disparities. This heat map actually hides a bigger story. Though this is by itself disturbing, the fact that patients have to travel thousands of kilometers to access what they think is high-quality, evidence-based cancer care, the story is not complete by itself. When you drill down deeper, and we did this state by state, this is the state of Uttar Pradesh. Even here, even within a state, you see inequalities. There are some cities within the state of Uttar Pradesh like Varanasi, Lucknow, and wide area no access to cancer care close to their homes. A similar story in Bihar, and somewhere which is very close to my heart, which is Northeast India, where even a 50-kilometer travel can take anywhere from 3 to 4 hours, given the difficult geographic terrain that people have to travel in the northeastern part of India. And the northeastern part of India is also has some of the largest or the highest cancer incidence in the world. So it's a double whammy that they are faced with there. A high incidence of cancer and lack of adequate facilities to manage cancer in that part of the world. Again, to illustrate the inequalities that we have, let me take you to a study that we did a couple of decades back. Many of you might know that trastuzumab or Herceptin is a wonder drug for breast cancer treatment. In HER2-positive women, it improved outcomes by more than 10%. And in the general scheme of things, most breakthroughs in cancer drugs have improvements in the range of 3% or 4%. So trastuzumab was truly a wonderful drug. So we looked at consecutive patients at the Tata Memorial Hospital 2 decades back who were able to get the drug. We looked at 440 patients who were HER2 positive, which meant that they would benefit from the drug. And we realized to our dismay that only 38, less than 10% of them actually ended up getting the drug. And when we look at the 38 patients even closely, half of them got it because they were part of a clinical trial, and only 4% of individuals could afford to get the drug paying their own money. And thankfully, the situation with Herceptin has changed now, thanks to generics becoming far more affordable. But even today, only 60% of patients who are eligible to get the drug at the Tata Memorial Hospital actually end up getting the drug. Added to that is the projected increase in the cancer burden in the country. It is expected that over a 25-year period, we'll have a 70% increase in the absolute number of patients diagnosed with cancer. So are we equipped to face this increasing burden? We have geographic inequities in access. And I think when you look at this graph, the height of the bars corresponds to the availability of facilities. And as you can see, southern India stands out by having the maximum number of facilities and the maximum access to cancer care anywhere in the country. There are economic inequities in access. In spite of all the investment that governments have made, today 20% of overall healthcare expenses, this is not limited to cancer care, this is all of healthcare expenses, are met from public healthcare expenditure. Over 70% of overall healthcare expenditure is still out of pocket, and it is estimated that every year 6% of India's population falls under the poverty line because of catastrophic healthcare expenditure. Just to give you context, I'll compare it. This is an unfair comparison, I must admit right at the beginning. I'll compare it with another democracy, but a high-income democracy, to just illustrate what the differences in the public healthcare expenditure is. Canada spends 11.6% of its GDP on public healthcare expenses. India spends 1.5% of its GDP on public healthcare. The GDP per capita in Canada is over $45,000, and in India it is over $2,300, which means that the average citizen in India, in Canada, the government expends over $5,200 per year on their healthcare, whereas in India it is just over $35. So we really have a long way to go, and I think it's our responsibility as physicians to constantly advocate with governments to increase their expenditure on healthcare. Ernst & Young, one of the consultancy firms, did this gap analysis of cancer care facilities in India a couple of years back. And as you can see, whichever metric that you might use to determine whether we have adequate facilities, whether the first one, which is comprehensive cancer care centers, whether it is radiation equipment, the number of medical oncologists, the number of radiation oncologists, and medical physicists, all of them are in deficit in anywhere from a requirement of 1.3 times increase to 2.5 times increase to be able to meet the needs of cancer patients today. The only area where we seem to have adequate number of specialists is in radiation oncology. But unfortunately, this is not met with an equivalent number of radiation equipment. What we have today is only half of the radiation equipment that we truly need in today's world, just to deal with today's burden. I'm not talking of the 70% increase that we'll have to deal with in the next few years. Just to give you context, again, a comparison with the MD Anderson Cancer Center. We are used to be sister institutions with the MD Anderson Cancer Center, and we are remarkably similar in many ways. We see almost the same number of new patients with cancer annually. The MD Anderson sees 42,000 new patients, whereas we see 46,000 new patients with cancer every year. MD Anderson has 1,700 physicians and researchers to treat or manage these 42,000 patients, whereas we have 188. So it's an order of magnitude lower when it comes to how we are able to manage patients with cancer in this country. So this brings us back to this very disturbing heat map and how we could look at this in a very different way. So the government of India, in its wisdom, asked us to start several more cancer centers, and so we did. Over the last 11 years, we have started 8 more cancer centers in different parts of the country. 2 in Varanasi, 2 in Punjab, 1 in Visakhapatnam, 1 in Guwahati, and 1 in Muzaffarpur in Bihar. And we are in the process of starting another one in Odisha near Bhubaneswar. But given this extreme density, starting new cancer centers can never be a long-standing answer. So we had to come up with something fairly disruptive, something which was completely unconventional in a way to tackle this increasing burden and to be prepared for what would be a true pandemic of patients diagnosed with cancer over the next 2 decades. Which is why we thought of creating a network of cancer centers, existing cancer centers within India, in an effort to reduce the gap in quality of care that was being offered. 12 years back, in August of 2012, we invited the directors of the then 29 regional cancer centers to come to Mumbai, to Tata Memorial Hospital, to brainstorm on whether a network of this nature would actually work. There was a lot of skepticism at the beginning because something like this had never been attempted. not just in cancer, but in any other disease area in the country. With the result that out of 29, only 17 of the directors participated in it. And over the last 11 years, this movement has grown by leaps and bounds, and I'm really happy to share that these 17 centers have now grown to a much larger number, which, as you can see today, spans the length and breadth of the country, with every state and union territory being represented in this map of the network. So today, we stand at 320 cancer centers, realizing the importance of research. There are several research institutions which are part of this. We don't do anything without patients being involved, so there is a very strong patient movement. We have patient groups as part of this. We have professional societies and charitable organizations, all of which are part of this network. This network between the member centers treats over 800,000 new patients with cancer annually. And just to give you context, that's approximately 60% of all of India's cancer burden. And you can imagine that any initiative that is taken through the National Cancer Grid has an ability to scale up fairly rapidly. There are three main pillars on which the Cancer Grid was created, and to this date, they remain the most important three pillars. The first, and probably the most important one, being to create uniform standards of cancer care across the country. A very ambitious and very audacious aim, but something that we are very, very committed to work towards. The second, to address the gap in expertise, is to create and develop human resource, and we are looking at this in very different ways, including task shifting and task skilling. The final pillar on which the Cancer Grid was created was to have a ready platform for collaborative, multicentric cancer research. One of the first initiatives that we took, as any good organization should, is to have a gap analysis of what was missing in cancer care in the country. We looked at the growing burden of cancer, the demography and the epidemiology. We looked at the current status of cancer research in India, looking at the priorities that we had and how we compared with global results. But most importantly to me, the question of how we could deliver affordable, accessible cancer care to all our patients. And for those of you who are interested in this, though this is a decade old, this is a series of papers that we brought out as a Lancet Oncology Commission in 2014. Given the fact that uniform treatment was one of our main goals, we set up a committee, a large committee which was disease specific, looking at emerging guidelines for cancer care in the country, and we brought this out as the first edition in 2017. But what we rapidly realized was that just bringing out evidence as guidelines was one thing, and implementing them was something entirely different, primarily because of the constraints of cost, the constraints of available expertise and infrastructure. So for the second edition of the guidelines, which came out in 2020, we got over 250 of India's top oncologists spending almost 6 months working on treatment guidelines and coming to a consensus, and we brought this out as resource stratified treatment guidelines. So what this effectively means is that instead of having one single guideline, we divide it into essential, optimal, and optional. The essential is the bare minimum that is required for treating cancer. If a cancer center doesn't have the necessary infrastructure or expertise to treat based on the essential guidelines, patients should be referred to the next available center. Optimal takes into account the best available evidence, provided the interventions are cost effective. We do not include marginal benefit treatment improvements at a high cost as part of the optimal, because we are very conscious of the fact that public healthcare expenditure on cancer is limited and we need to use the money judiciously. The final, which is optional, just takes evidence into account without any consideration of cost. So if an extremely wealthy individual wants to spend millions of rupees on cancer care for very marginal benefits, they could still get covered through the optional guidelines. And when we launched these guidelines in 2019, in the annual meeting of the National Cancer Grid, the then additional CEO of the National Health Authority, who was part of the meeting, immediately accepted these as guidelines that the National Health Authority would adopt and link to reimbursement under the Ayushman Bharat scheme for patients getting cancer care. Just to keep the whole process transparent, the process of adapting these guidelines and adopting these guidelines was published to make it very transparent in the way that the guidelines were developed, because there could be potential for a lot of conflicts of interest coming into the recommendations that are made as part of these guidelines. And this is also a ready draft for individuals involved in treating other diseases to adapt guidelines of a similar nature. Given the fact that public healthcare expenditure is what it is, and the recognition that there are several commonly formed practices which are probably either low value or possibly even harmful for patients and coming at a high cost, we came out with what we call the Choosing Wisely India recommendations for cancer care. And for those of you who are not familiar with the Choosing Wisely movement, this was started by the American Board of Internal Medicine in an effort to identify common practices, routine practices in healthcare, like the overuse of antibiotics, the overuse of blood transfusions, and so on, things that are low value, high cost, and possibly even harmful for patients. And we came out with a set of 10 recommendations, which today are hopefully being adopted by several cancer centers across the country. Realizing that public healthcare money needs to be well spent, we brought in health economics evaluation into our guidelines to link the resource stratified guidelines. We no longer rely on individual judgments to decide whether something is cost effective or not. We have a formal system of adaptive health technology assessment, a far rapid way of doing health economics assessment than the traditional way, which takes anywhere from 12 to 24 months. This has been done in collaboration with the Center for Global Development in Europe, the same group which helped develop the NICE guidelines in the UK. We have so far evaluated 10 pivotal interventions, all in a period of 1 year, and we are expanding the scope of this health technology assessment in partnership with the Department of Health Research, Government of India. Quality is central to everything that we do within the cancer grid. It is important to provide low-cost care, but it cannot happen at the cost of quality. So we instituted a policy of institutional peer review, which very simply put means that individual cancer centers, individual hospitals can volunteer to get their own institutions reviewed by an expert group. We put together an expert group in various specialties from within the National Cancer Grid who exchange performance metrics with the individual centers which volunteer to get themselves peer reviewed. It culminates in a site visit which lasts 2 to 3 days, where a more detailed evaluation of the cancer center or the hospital is done, and the final report is shared with the leadership of these cancer centers. So as you might imagine, in a situation like India, there was a lot of reluctance initially when we started this for cancer centers to volunteer to be peer reviewed. And it is remarkable that it was some of the smaller centers, some of the less experienced, less resource centers which actually put their hands up and said, we want to be peer reviewed. And we championed their cause, and we helped them achieve many of the recommendations that the peer review team did at not a high cost. And therefore now, today we have a waiting list of centers wanting to be peer reviewed by an expert group within the cancer grid. As I mentioned, quality extends to all aspects of cancer care, and nothing more than in something what is fundamental to cancer control, which is pathology diagnosis. Unfortunately, in India, there are no standard ways of accrediting the quality of pathology reporting. You have the NABL, which accredits labs, which looks more at systems and processes, but very little to do with the actual interpretation, the grossing that goes into pathology, and so on. Many of you might have heard of the College of American Pathologists or the CAP accreditation program. Tata Memorial goes through a CAP accreditation of its own, but you'll also realize that it's an extremely time-consuming, effort-intensive, and very expensive way of getting your quality accredited. So what we did was to create a leaner version of CAP. We run it through the National Cancer Grid, and it is offered completely free of cost to all members which are part of the Cancer Grid. Just to give you context, for CAP accreditation, Tata Memorial spends over 55 lakhs of rupees per year to get themselves accredited. So we do this through on a web-based platform, and we offer this completely free of cost to all members of the Cancer Grid. Realizing the increasing importance of molecular pathology, we have extended what was originally only for H&E sections and immunohistochemistry to include molecular pathology, quality assurance as well. And again, this is free of cost to members. Many hospital administrators, including myself, have grown to these positions of leadership with very little training or very little formal training in leadership skills. Nor have we been trained in quality improvement. The result that we are just stumbling and doing trial and error, and in my case at least more error than trial, and you come up to a level of maturity which hopefully is good enough to run a hospital well. So we train individuals through the National Cancer Grid on quality improvement. So we have trained close to 108 cohorts, which are teams within these institutions, on how to improve quality within your own institution. Each of them has a project which they take to completion, and this is done through a blended learning module in collaboration with the Stanford University. That heat map showed you how far patients are willing to travel to get an expert opinion. So to help at least some of them, we created a web-based platform called Navya, where all that a patient needs to do is to upload the reports in whatever format they might have. It could be handwritten notes by a general practitioner or a physician. It could be DICOM images of CT scans and MRI scans. It could be pathology images digitally scanned. All of this can get uploaded onto a secure website, where the back end of Navya then converts this into a structured format, which is sent and shared across experts within the cancer grid. The expert then goes through these reports and sends an opinion, all happening in a median turnaround time of under 24 hours. All of us treating cancer know the importance of multidisciplinary tumor boards. There is strong data to support the fact that patient outcomes are better if treatment decisions are taken by a tumor board rather than by individual physicians. Unfortunately, some of the smaller centers lack the bandwidth to have site-specific experts discussing these issues. And to overcome this, the National Cancer Grid created a virtual tumor platform, a tumor board platform, almost 7 years back. And so far, over 1,100 such tumor boards have been conducted, and over 5,500 patients' clinical situations have been discussed in these tumor boards. So initially, we thought of tumor boards as a way of helping out with complex clinical treatment decisions being taken. What we didn't anticipate, but what was a very welcome side effect, was the fact that this was an excellent tool for case-based learning and continuing medical education. So some of the smaller centers, some of the less experienced centers, which were putting in very basic clinical situations earlier, got trained on how to handle these easy situations, and now the kind of cases that are discussed in these virtual tumor boards could challenge some of the best brains in the world. Given the fact that we are a large group, we negotiated with journal publishers to get group subscription for medical journals and textbooks. As all of you know, medical journals and textbooks are expensive, with the result that the less resourced centers, even those who run postgraduate programs, are unable to subscribe to these journals. So we negotiated as a group with these journal publishers, and we're able to achieve discounts ranging from a minimum of 50% to a maximum of 90% discount on what an individual center would have to pay if they were to subscribe for these journals themselves, clearly democratizing access to continuing medical education. We also have several large centers which have library collections of their own. So what we did was to aggregate the library collection or the knowledge resources of these centers, and any member or any individual physician of a center which is part of the National Cancer Grid can put in a request for any of these individual articles, and the article will be sent to them in a median turnaround time of under 24 hours. We leverage technology quite heavily. We have open online courses, something similar to edX or Coursera, where we deal with all aspects of cancer care. And when the COVID pandemic hit us, we actually used this as a platform to disseminate knowledge about the SARS-CoV-2 virus, as well as best practices with diagnosis, infection control and prevention, and treatment of the COVID-19 pandemic. So we had very little lag time that was required to bring up this information sharing processes in place. I did mention to you the challenges of traveling from places like the Northeast to cities like Mumbai and Delhi for patients. It's not just for patients that they find it challenging. Even physicians treating cancer, doctors treating cancer, pathologists find it difficult to attend conferences and update their knowledge. So what we did was something very innovative. We flipped the learning system around. Instead of expecting these physicians to travel to cities like Mumbai, Delhi, Chennai, we send a group of experts to travel and run a series of workshops in the Northeast part of India. And what we did was run 2 cycles of these workshops where we covered 11 cities. We covered 6 cities in the first round and 5 cities in the second round, where, as you can see on the map here, covered most of the places in the Northeast, thereby bringing continuing medical education right at the doorsteps of these physicians and not just restrict ourselves to cancer care. Grown by the success of this, we have now decided to expand these services to other parts of the country. We have already done some pilots in Karnataka and Andhra Pradesh, but we also plan to increase the scope to include 2 very neglected areas in cancer control, the first being palliative care and the second being community oncology. So we are in the process of working with oncologists in the northeast part of India to run a series of workshops on palliative care training as well as community oncology, so that public health also gets covered in these areas. Our success with negotiating with journal publishers encouraged us to negotiate for cancer drugs. We initially started with negotiating for cancer equipment, but this was a much more difficult nut to crack, so we decided to go with cancer drugs. So the process we adopted was to aggregate the demand from individual centers. We pooled their volumes, and because of the volumes that we have, we are able to negotiate much harder with the pharmaceutical industry. And what we did was a central tendering and negotiation process. Tata Memorial is a government hospital, so we have to follow Government of India norms for tendering and negotiation, so it was done very transparently. Once the price was confirmed and negotiated, the final contracts were signed between the individual centers and the pharmaceutical companies. And what we were able to achieve was a minimum of 23% discount on MRP to a maximum of 99% discount on MRP, with the overall average discount achieved being 85%. So in effect, what this meant was that a medicine which cost 100 rupees was now suddenly available at 15 rupees, dramatically reducing the cost of cancer care for patients. We believed strongly that electronic medical records were the way forward, but we also were conscious of the fact of the limitations of electronic medical records. Unlike the US, where the EMR industry is dominated by 1 or 2 major players, the EMR industry in India is extremely fragmented. When we last looked, there were over 30 EMR vendors, each of them, and none of them had more than 10 or 15 installations to boast of. Given this very diverse EMR scenario, what we wanted to see was to create a proof of concept on whether data could be shared between centers of the National Cancer Grid in spite of having different EMRs. And we worked with a company called ThoughtWorks based out of Bangalore, in which we were able to develop a proof of concept that in spite of having different EMRs, using patient consent, a very robust patient consent platform, we were able to share patient records across different EMRs. Though we did this independent of the government, what happened when the government decided to launch what was then called the National Digital Health Mission, what is now called the Ayushman Bharat Digital Mission, and they were looking for proof of concepts which had been already developed, we had this ready, and they directly picked this to become what is now at the heart of what the Ayushman Bharat Digital Mission is all about. The third pillar on which the National Cancer Grid was created was research. And we believe very strongly that the network that we have created is a very rich resource for cancer research, not just for India, but globally. The NCG funds cancer research itself, in addition to putting together grants for external funding. But the NCG funding comes in only if these following criteria are met. First, it needs to be a multi-centric collaboration. We do not fund single center studies because we think it's an inefficient and not a generalizable way of doing research. We fund only if the cancer that is being studied is either common or unique to the region. We do not fund rare esoteric cancers unless there is a very strong reason for doing so, unless it's an orphan disease which has not been researched elsewhere. If it is an interventional study, it needs to be something which is cost effective, so that if the research proves that the intervention is effective, cost doesn't become a constraint in the implementation of the research. Much of the research that is today coming in from high-income countries is implementable in less than 5% of India's population, primarily because of cost constraints. Anyone who gets funded through the Cancer Grid has to commit to share their data in the public domain so that other researchers can mine the same data and come up with newer findings of their own. And finally, but most importantly, we do not fund studies unless there is a strong public and patient involvement in the research right from the beginning. These are some of the examples of the studies that we have funded through the National Cancer Grid. And I must point out a couple of examples just to demonstrate the strength that we have in this network. The first study, which is ICICLE, was done in acute lymphoblastic leukemia. And for those of you who are not in the field of pediatric leukemias, most studies done in the West have, in spite of having cooperative oncology groups, and the pediatric group is something which is very, very good at cooperative groups, the sample sizes have ranged anywhere from 300 to 400 patients at the most. A couple of years back, we've completed this trial and we recruited over 2,200 patients, given the numbers that we have within the cancer grid. We also look at very local and indigenous problems. We look at solutions which are indigenous. So curcumin, which has long been touted to be an anti-cancer agent, has just gained its name with virtually no evidence to support it. We wanted to test this in a robust randomized trial, and so we are looking at the use of adjuvant curcumin after completion of treatment in advanced head and neck squamous cell cancers. And this is a 2x2 factorial trial, the other part being metformin. Again, an off-patent anti-diabetic drug which is being repurposed and has shown some observational data to have anti-cancer effects. So these are all interventions which, if proven to be effective, and we will not compromise on the quality or the integrity of these studies, if proven to be effective, can be implemented right away without constraints of cost. And all of this have been done with a study expenditure which is a fraction of what it would have cost if we were to run the same study in a high-income country. We all know that physicians and researchers in India struggle for time to do research, and many of the pain points that they undergo are actually administrative. Things like what is the appropriate biostatistical support that you need, what kind of regulatory submission do you need, insurance, contracts, and so on. And to help researchers with these pain points, we created the NCG Clinical Trials Unit and the Academic Contract Research Organization, which helps researchers with the nuts and bolts of doing research. The Credo workshop has been one of our biggest success stories over the years. And for those of you who don't know about this, this is a kind of a boot camp for training on how to do research. As most of you who've gone through the medical education in India know, there is very little training on how to do research in your undergraduation and post-graduation during your medical education. So to overcome this, what we did was to create this workshop. There are only 4 such workshops globally. The first was out of Vail, California. The second was initially at FLIMS in Switzerland, but now has moved to Zeist in Netherlands, in Europe. The third in Sydney, in Australia. This is the only such workshop which is run out of a low middle income country. And the way the workshop works is that a researcher or a clinician comes in with a one-page research concept, a very vague idea at the back of his or her mind. And over a period of 6 very intensive days in a residential workshop, it is thrashed out with experts in the group, who then convert it into a full-fledged research protocol at the end of 6 days, ready for submission to the ethics committee. We have a very high faculty to participant ratio. The next workshop is due from the 4th to the 9th of March next month. And we have 81 participants and 45 faculty. So it's a 1:2, or actually more than a 1:2 faculty to participant ratio, because the strength of the workshop is one-on-one mentoring in small groups and how these protocols are developed. So close to 400 researchers and biostatisticians have been trained in these workshops over the last 8 years. And we are hopeful that we will continue to do this in the near future as well. Given the success of this workshop, we were approached by several international organizations to partner with them on helping mentor early career researchers from other countries as well, other low middle income countries, and they felt that the Credo workshop offered a much more diverse participation to participants from low middle income countries than the Vail and the FLIMS, which is all predominantly 90% drug development based. Whereas the Credo workshop is a very good mix of surgical, radiation, medical, oncology trials, as well as palliative care, pathology, anesthesia, and so on. It's a very diverse group of protocols that are getting developed. And currently we are getting funded through the WHO Southeast Asian Regional Office, the American Society of Clinical Oncology, the National Cancer Institute in the US, King's College London, and several other international and national organizations, City Cancer Challenge. So many of these fund participants coming in from other low middle income countries to participate in this. And currently 40% of seats in the workshop are for participants from other countries, with 60% coming in from India. And for those of you who are interested in learning more details about this workshop, there is this publication in the Lancet Oncology which describes it in more detail. Based on feedback from the previous workshop participants, what they told us was that going through the 6-day workshop was fine, but they also wanted continued mentoring on newer research problems that they were coming up with. So we started a virtual platform wherein newer research studies can be discussed, and experts from the same faculty that comes for Credo continue to mentor these participants for future research projects that they might have. More recently, we got together with some of the top global experts in cancer research. The author list here has the Chief Scientific Officer of WHO, the Director of the International Association for Research in Cancer, the Center for Global Health of the National Cancer Institute of the US, several other experts from across the world to brainstorm on what should be the priorities for cancer research in low and middle income countries, but looking at it from a global perspective. And much of the feedback that we got after we published this paper was the fact that we had actually shortchanged ourselves by calling it research priorities for LMICs, and most of them felt that these should have been priorities even in high-income countries as well. But we deliberately labeled this as low-middle income countries for a specific reason. These were the 5 key priorities for research that we identified. The first, to reduce burden of patients presenting with advanced disease. The second, to improve access, affordability, and outcomes in cancer care via solution-oriented research. The third, looking at health economic evaluation and health technology assessment for newer cancer technologies and interventions. Fourth, to improve quality and for implementation research. And fifth, to leverage technology to improve cancer control, supported by robust scientific evidence. Now, all of you might think that these are very basic, very simple, straightforward priorities to identify. But the reason we felt that it was important to actually spell it out in as many words is the fact that if you look at much of the cancer research that is currently done anywhere in the world, none of these 5 research priorities are addressed. We did a study of 700 randomized trials in cancer done over a 5-year period, where we looked at what were the priorities that they were looking at. 92% of the 700 trials were led out of high-income countries. 8% were led out of low-middle-income countries. This is in spite of the fact that 70% of cancer deaths in the next decade are expected to come in low-middle-income countries. So clearly, there is a very big skew in the prioritization of where research should be done. Again, importantly, 87% of the 700 trials that we looked at looked only at systemic treatment, which means chemotherapy, precision medicine, immunotherapy. Just 13% of studies were done on surgery, on radiation oncology, on palliative care, and survivorship. And the latter 4 contribute so much to cancer control that it is genuinely something that we should be ashamed of, that we have not prioritized these areas of research as much as we should. Recently, these 5 key priorities were identified for a joint grant between the National Cancer Grid and the Indian Council of Medical Research, which had matched funding to support randomized trials looking at these 5 key research priorities. And we have just awarded 9 grants to out of 135 applications that came in. And we are hopeful that at least in the near future, some of these priorities will have questions answered. So this is the ICMR NCG collaboration on joint funding for these trials. We believe in working very closely with the government because the government has a major say in healthcare delivery. So we worked with the National Health Authority in rationalizing some of the packages of the health benefit packages that come under the Ayushman Bharat scheme. But to us, more importantly, we were able to link the evidence-based guidelines of the National Cancer Grid to reimbursement under the scheme. And to this day, though this was 5 years back, to this day, no other disease area other than cancer has guidelines being linked to reimbursement under the scheme. So what we were able to achieve is the fact that we are automatically able to get quality into the equation at least for the 40% of patients in the country who are covered by the Ayushman Bharat scheme. Based on the success of the Cancer Grid and requests from several other countries outside of India, we launched the Center for Global Oncology under the National Cancer Grid, and several other countries and hospitals from several parts of the world have now become part of the Cancer Grid fraternity. Recently, last year, we were requested by the WHO Southeast Asia region to establish a Southeast Asia Cancer Grid, which would be mentored by the National Cancer Grid, and we are in the process of formalizing this relationship in a meeting that we will have in Nepal in May this year. We were recently funded by a philanthropic organization called Koita Foundation to set up a Center for Digital Oncology in an effort to centralize all the NCG efforts on digital health. And we truly believe that adopting digital tools in a scientific way can help us leapfrog some of the advances that have been done in high-income countries in a much shorter time. And we are looking at creating a separate staffing for this and looking at specific problem statements in digital health which can be addressed through this center. As I said, we believe in working closely with the government. This was an MOU that we signed with the NABH, the National Accreditation Body for Hospitals and Healthcare Providers, so that the digital health standards or the digital health record standards that we would develop under the National Cancer Grid was aligned and in harmonization with the NABH digital standards as well. These are some of the future steps that we hope to achieve over the next few years. Given the numbers that we have, we hope to create a national cancer database, which is an integrated data collection and aggregation. Dr. Pillai and I were speaking about this on our way to this hospital this morning. The ICMR cancer registries between themselves cover less than 10% of India's population. And that 10% is extrapolated to the rest of the country, which clearly means that there is probably a lot of underreporting more likely than over-reporting that is happening with cancer data across the country. So imagine if we were to just able to get the data from the 300 plus centers within the Cancer Grid, we automatically multiply the ICMR registries sixfold. From 10% it goes up to a 60% coverage of patients diagnosed with cancer. As I mentioned earlier, we hope to expand the traveling schools that were run successfully in surgical pathology to palliative care and community oncology as well. Given the deficit in leadership training in the country, at least in cancer care, we expect to start a leadership development course, which we will be doing in collaboration with ASCO and the Princess Margaret Cancer Center, both of which run a leadership development course of their own. Given the fact that we are a very large group, we are planning to create a rare cancer registry and an exceptional responder registry. And these are extraordinarily useful resources for researchers across the country and probably even across the world. Rare cancers are difficult to manage because they are rare and there is not enough material or data to help with the research. But given that we are a group which treats over 800,000 patients, rare cancers are no longer rare. We will still be able to get the numbers to be able to do meaningful research. We hope to be more ambitious with our group negotiations, going beyond the success that we've had with drugs to include equipment. So just imagine collecting requirements of, let's say, 50 PET scanners or 50 MRI scanners or CT scanners and negotiating with Siemens or GE as a group. The kind of discounts that we'll be able to achieve will be substantial. We are in the process of setting up a health economics cell so that our health technology assessment becomes a little more formal and organized. We are in the process of setting up a foundation called the NCG Foundation so that we are able to generate funds from philanthropy and corporate social responsibility to fund several of these initiatives and to expand the scale of these initiatives. And we also hope to partner, and we've already had interest being expressed by groups such as Google, Microsoft, ChatGPT, to work on initiatives which will help with digital health initiatives as well. So I started this whole talk with this rant on inequality and how we needed to work hard to overcome this. The fundamental reason why we have these inequalities, at least in cancer care, is that we've been traditionally looking at progress in cancer care through a very narrow lens. Usually, if you had to go to ASCO or ESMO or any of the top cancer conferences in the world, and if you were to ask the average participant, what do you think is progress in cancer medicine and cancer research, you would more often than not be met with an answer which looked at some of the cutting edge advances in cancer research. you'd be spoken to about targeted therapy, precision therapy, immunotherapy, robotic surgery, and proton therapy. I have nothing against these advances. I think these are extremely important advances to make. That is how science progresses, and that is how we'll be able to treat our patients better. And I think it is important that we need to continue investing in these. And very naturally, healthcare systems also invest in these advances, and I have no quarrel with this. But the reality also needs to face the fact that while we might chase these esoteric, extremely important, but unfortunately very expensive new advances, we can't forget the basics. We don't have similar data for India, but I'll use the example of Africa to tell you how we have failed so badly in making sure that we get our basics right. The pathologist availability in high-income countries is one pathologist per 15 to 20,000 population. Compare that to Africa, where you have one pathologist for 2.3 million people. And unfortunately, even in Africa, where they're looking at improving cancer control, they are chasing these fancy new tools and not looking and getting their basics right. There are several countries in Africa which don't have a single radiation equipment in their entire country. They need to go outside the country even to get something as basic as radiation therapy. And without those basic infrastructure in place, it is probably criminal to chase these new expensive technologies. I'll use this example of a study that we did. Again, unfortunately, we lack data in India, but this is data out of Europe, which looked at outcomes of cancer treatment in several countries for several cancers. So the horizontal bar tells you, the left end of the horizontal bar tells you what the worst performing countries had by way of 5-year survival, and the right extreme of the horizontal bar tells you how the best countries fared. And let me take this example of head and neck cancer, a cancer which is very, very common in India. The worst performing centers in Europe had an 18% 5-year survival, 1/8. The best performing centers had survivals in the region of 55%. So more than a 35% absolute difference in survival outcomes within the same geography, most of them spending almost the same amount of money. So it wasn't just the money which was making the difference, but such varied results as far as the outcomes go. Clearly demonstrating that while money is important, adherence to quality, adherence to protocols, and adherence to evidence-based medicine and implementing what we already know is so critical in achieving these outcomes. I spoke of a 35% improvement, absolute improvement in outcomes. There has not been a single intervention in modern medicine in the last 3 decades which have had a 35% absolute improvement in survival, with very few exceptions like probably Gleevec or some of these molecules. So clearly demonstrating that if we are able to implement what we already know, we don't need to chase these extremely expensive new interventions that are coming in. So what do we need to do to achieve those? In my mind, we need 3 major shifts, and predominantly this needs to do with our mindset and our approach to healthcare delivery rather than anything else. The first is to change the global mindset and our own mindset and look for value-based interventions. Every time there's a new intervention that's coming in which is supposed to progress medical science, let's run it through the lens of, is this truly value-based? The second, and I think this is the most important aspect, is the fact that we need to fund human capital and social development. We cannot look at medical progress in isolation, the newest drugs, the newest surgical tech tools, or the newest radiation equipment as a way of improving outcomes. What we need to do is to invest in people, invest in basic technology, and ensure that we are able to offer safe and affordable cancer care to the vast majority of our patients. And finally, as the healthcare profession, we need to introspect and we need to keep ourselves accountable and be open to regulation, because we are in India a largely unregulated healthcare delivery system. And unless we overcome this mental block that we are accountable and we need to keep ourselves open to being challenged, we will not really get very far. And while the West has looked predominantly at cancer moonshots, there have been 3 cancer moonshots that have been announced so far in the United States. And I have nothing against moonshots. I think moonshots are great. We need to follow those. We need to go behind those newer technologies. What I would advocate for is earth shots, or back to the basics, or making sure that the basics are right, and then go for moonshots. I'll end with acknowledging some of the organizations that have supported the National Cancer Grid over the last 12 years of its journey. Several national and international organizations which believed in us and supported us even at a time when we hadn't proven ourselves and where the outcomes were not very clear. And I'm taking this opportunity to express my deep sense of gratitude to all of these organizations for believing in us and helping us grow over the last 12 years. Thank you very much for your attention, and I'm actually happy to take any questions.
Thank you, sir, for giving us a snapshot of your work to reduce the disparities in medical care and evidence-based standards of care to all. I'm sure it has inspired everyone here to do a bit and work on providing equitable care for everyone. Thank you, sir. And may I request Sri Sibin Sebastian, Vice Chairman, KMC Hospital, to hand over the memento to Dr. Pramesh. So please accept this memento as a symbol of our gratitude for sharing your knowledge and insights with us today.
Next, it's our privilege to call upon Dr. M.V. Pillai sir to felicitate the event and give the talk on breast cancer screening, current concepts and controversies. Dr. M.V. Pillai, after graduating from Thiruvananthapuram Medical College, did his MD in medicine from Kerala University, following which he worked at Thiruvananthapuram, Kozhikode and Kottayam Medical Colleges for 10 years. He then underwent PG training in hematology at Auckland University, New Zealand, before proceeding to USA for fellowship in hematology and oncology at Medical College of Virginia. Triple board certified in medicine, hematology and medical oncology, he served in United States Air Force Medical Corps as Lieutenant Colonel and Chief of Oncology at the Malcolm Grow Air Force Medical Center, Washington, D.C. He was clinical professor of medicine at George Washington University before joining Thomas Jefferson University, Philadelphia as clinical professor of oncology, continuing to date. He is currently the president of International Network for Cancer Treatment and Research USA and a member of the Global Initiative on Breast Cancer. Dr. Pillai is also a senior advisor to Global Virus Network, in which capacity he established the Institute of Advanced Virology in Kerala. He was the organizing secretary for International Conference on Treatment of Radiation Injuries at Washington, D.C., with participation of experts from USA and Russia, among other nations. In 2002, he conducted the national meeting in Rajasthan to form a network of oncologists in India, Indian Cancer Care Network, closely on the heels of National Cancer Care Network, under the auspices of Tata Memorial Hospital. He has also received a memento from the President of India, Dr. APJ Abdul Kalam. Dr. Pillai is presently a member of the Governing Council of Kerala's RCC and Chairman of Advisory Board of K.M. Cherian Institute of Medical Sciences Oncology Center. Hearty welcome to you, sir. Over to you.
Thank you. Thank you for the kind introduction. And distinguished guests and Board of Directors member, Vice Chairman Mr. Sibin Sebastian, Board of Directors, Managing Director, Father Alexander Kudarathil, my colleague and best friend, Dr. Sara Isho, and Dr. M.R. Rajagopal. And of course, I have to specially thank two distinguished celebrity scientists of India, that's C.S. Parmesh and also Dr. Shivakumar Serin, who found time in spite of their heavy schedule and hectic travel to be with us on this most unforgettable moment in the history of the K.M. Cherian Institute of Medical Science. It's unforgettable to me for a variety of reasons. The famous Russian novel, you probably have Michael Sholokhov's And Quiet Flows the Dawn. I'm going to paraphrase this today because next to me on this beautiful building is a river which is celebrated both in history and in our ancestry, the Pamba. The Pamba River is associated with two spiritual movements of the people of Kerala, the Shabarimala and also the Maraman Convention. There are not many rivers in the world which can be associated with the cultural exuberance and the spiritual outlook of a group of people. And I was wondering why I was brought to this podium today, because in the old age, you start becoming more and more a believer in faith. The fundamental difference between science and the faith: in science, we need evidence to believe. In faith, it's just the opposite. You need to believe first to see the evidence. I was stunned to see that the National Cancer Grid came in 2012, 10 years after I made a humble beginning to bring it to India on the heels of the National Cancer Network of USA. We now know that in science, we confirm things by evidence-based medicine. You need to show the evidence either by double-blind, prospective, randomized studies. But it's not always possible. Even when it is possible, there is something called pharmacogenomics. What is positive in a Caucasian population need not be positive in an Asian population. The best evidence of such divergence in clinical response is seen in adenocarcinoma lung. We know that the Eastern women with no history of smoking harbor a mutation which responds beautifully to EGFR blocking drugs. So the response is excellent in Asian women, but not as much in the African American or in the Caucasian population. So the pharmacogenomics is coming to the fore at a time we have realized that nobody is an expert in any field these days. If anything that we learned from the COVID debacle is the fact that we no longer have somebody to be considered as a role model. All the big countries faltered their legs. They made their mistakes. Even international institutions like CDC and WHO made big blunders. So a time has come in the era of second globalization, where the original globalization is fast on the decline and a multipolar world order is being established in the post-COVID situation. The answer to many of our questions have to originate within our country. Gone are the days we can blindly follow the American style or the British style, the French, Japanese or Australian style. In that respect, I was stunned on the banks of this holy river. What made me bring to this shore of this Pamba River, the district where I was born, at the sunset years of my life? And here lies. In 2022, I was fortunate to introduce the concept of National Comprehensive Network in India, under the leadership of Dr. Desai, the then director of the Tata Memorial Hospital. It was attended by none other than perhaps the best president we ever had, a scientific visionary, Dr. APJ Abdul Kalam. The Tata Memorial and the then president was kind enough to give me a memento which you probably saw. I didn't expect that this is going to bloom. 10 years later, Dr. C.S. Pramesh takes it over and establishes the most impressive, incredibly powerful and strong movement in India, the National Cancer Grid. And quite flows the Pamba. This is where you have to believe in certain things which we cannot see in science. If you do something with a dream, just like what Paulo Coelho said, the whole world will conspire to make you gain that. So what Paulo Coelho said turned out to be true. When I introduced the National Cancer Care Network in Rajasthan, I had no way of predicting how it's going to turn out. It had a dormant period of 10 years. Now we have a beautiful tree, a flowering tree, a fruit tree, the National Cancer Grid. I congratulate Dr. C.A. Pramesh for initiating that and bringing to the banks of a river which takes the origin of my birth. It is the same place where I was born. How can you resist from thinking that there are superpowers there? And no wonder Pamba became the spiritual river for two prominent religions of this world, the Christianity and the Hinduism. I'm not trying to bring any superstition, but I cannot contain my wonder at this present serendipitous coincidence. Now, the talk I am going to give you is intentionally selected. Intentionally selected because Kerala, according to the ICMR and according to the prestigious medical journal Lancet Oncology, leads in the incidence of breast cancer. We don't need any confirmation. Ask any oncologist here, they can give you the number of patients they are treating. Nobody knows why. This is a multi-ethnic group. A lot of racial and ethnic mixing has occurred here. And the Jewish people were tickled to hear that in Mattancherry, some of their ancestors had a quiet and acceptable life. In fact, one of the Israeli prime minister openly made a statement in Israeli parliament that the only place of the world where no Jew was persecuted, all Jews were accepted with open arms, is a tiny state on the southern tip of India called Kerala. Even today, many Jewish academicians come to visit the Mattancherry synagogue. Now, that's apart from that. The Jewish people were appalled by the incidence of triple negative breast cancer in Ashkenazi Jews. Here we have a mounting incidence of triple negative breast cancer, and nobody knows why. The whole field is wide open for us to study. Ask any medical oncologist or radiation oncologist, they are surprised to see why the incidence is going up. But here is a blessing in disguise. These cases are not as bad, not all of them are as bad as we think. In contrast to the triple negative breast cancer in the Caucasian population, we have a divergent population of triple negative. Some are doing well, some not so well, and some have an indolent course. What is that factor X? The answer should come from institutions like AIMS, Cherian Institute of Medical Science, Oncology Department, in the next 10 years with the help of people like Dr. C.S. Pramesh. That's the whole purpose of my inviting him, compelling that he should be here and take up the leadership to develop this premier institute as a biomedical research center. Things are working in our favor. In fact, Tata Memorial is offering us support, not only through Dr. C.S. Pramesh, but I spoke to the professor of preventive oncology, Dr. Sharmila Pimble, who heads the preventive oncology. She is quite happy to help us in population studies. We are also connected to the Mayo Clinic, Dr. Karthik Ghosh, she's a Malayali, who heads their community oncology and very active in breast cancer screening. So it looks like more and more forces are joining together, justifying Paulo Coelho that if you really want to do something good, the whole world is going to conspire to help you to get that. Now, here is the topic proper. In the next 30 minutes or so, I want to take you through why the breast cancer screening is raising so many controversies. We all know that screening breast cancer can be helpful in reducing the mortality. If you all know that, why there should be a controversy? Go through these headlines. Who should be screened? This is an area which has been disputed. Right now, American Cancer Society or US Task Force recommends that screening should begin at the age of 40. Why 40? Why there is a magic number of 40? Why can't you do it at 30? And that's because of a variety of reasons. One, studies have shown that the incidence of breast cancer starts around the age of 40 and beyond. So there is no reason why you should start screening at the age of 20 or 30 and expose these girls and young women to ionizing radiation. We know that a chest X-ray takes about 0.1 millisievert. A CAT scan of the chest takes about 70 millisievert. And the mammogram, if you do it repeatedly, is going to add up to the radiation. There are other things also we'll come to very soon. So the Westerners came to an agreement that the screening should begin at the age of 40 by a process of consensus, not by evidence. Of course, they did some retrospective studies and found that the cancer is growing up after the age of 40. So instead of screening all women from young age, they started at the age of 40. The US Preventive Task Force initially didn't believe in it. And the US Preventive Task Force is a group of independent voluntary experts. For a long time, they said, you don't have to start screening at the age of 40, let's wait for the age of 50. Last year, September 2023, they changed their mind. All of a sudden, US Preventive Task Force is saying, let's bring it down to 40. Is this based on any new evidence? No. But on retrospective analysis and on pooling the large number of cases studied and what we call as a systematic analysis, they tend to agree that it's better to screen them early than wait until the age of 50. So right now, the Western population starts their screening at the age of 40. So that answers the first question, who should be screened? All women starting the age of 40 should have a basic mammogram, except patients with a family history of breast cancer. The patient's mother has breast cancer. The patient's first degree sister has breast cancer. They recommend bringing it down by 10 years. If a 42-year-old lady has a sister who is 32, then that's a stratified high-risk group. They do recommend screening them at the age of 30. Special group, high-risk group. Okay, the next question is, how often do you want to screen them? Do you want to screen them every year? Or do you want to do it every 2 years? Again, the answer has been in a murky area for a long number of years. Generally speaking, the American Cancer Society was recommending that if you start screening at the age of 40 or 45, then after the age of 50, you can split it into every 2 years with getting the equal number of positive outcome. So US physicians are caught between these two options now. Do we go by the American Cancer Society guideline of repeating it every 2 years in women after the age of 50, or do you want to do it every year? We'll come to that very soon. Why this is done is all the studies conducted have shown that those who are screened can be picked up in an early stage with a better outcome. The scare and the stigma attached to breast cancer is largely because these patients are presenting in the advanced stage, as you probably see here, with the fungating mass, and the women, particularly in Kerala, are very concerned about the stigma of cancer because they have children growing up, especially girls, and when the marriage proposal comes, if somebody points out the mother had advanced cancer, that's a minus point. And the stigma is what really prompts them to delay the treatment, delay reporting to the doctors. So the early form of detection can eventually take away that stigma. That is one of the goals of early detection. Now, when do you start screening? We answered that question. And where? Do you want to do it in all hospitals, or can we do it in a society as a population screening? I think that's where we are heading now. The population screening would start very soon. Last week we had a meeting with the health minister, health secretary, the DHS, DMA, and for the first time the government seems to be agreeing in principle that a public-private partnership should be brought into Kerala as quickly as possible. It's a policy decision. They're waiting for the cabinet or the chief minister to give the green signal. Such a private-public participation in Kerala is going to make a revolutionary change, because 14 private cancer institutes, including KM Chirya Institute, has signed up to support this movement. And this is really dramatic because some people are donating land. Every institution is donating their human resource. 3 of the institutions are ready to buy screening mammogram equipment. Many are willing even to go to the next step. In addition to the 2D mammogram, they are going to offer the 3D mammogram, about which we'll talk very soon. Now, how do you screen them? This is where I think the Tata Memorial Hospital has to be congratulated. The three ways of screening them, we all know about the breast self-examination. Women are encouraged to feel their breast and see if there is anything suspicious. Does it really work? It depends on what endpoint you choose. Generally speaking, in cancer treatment, we take one endpoint as the most critical. Does it reduce the mortality? Can you take 1,000 women who do the self-breast examination, take another 1,000 women who have never done that, and show that those women who did the breast self-examination had an improved survival? Unfortunately, such a study is not available now. So why do you want to do the self-breast examination? I think the only benefit is now young women start feeling their breast and get a feel of how things are evolving. Any deviation from the normal would encourage them to report to the doctor. Will it improve the chances of survival? It's very difficult to prove. I don't think any study is going to be done. Mainly because in cancer mortality, we always go by the all-cause mortality. It's not a disease-specific mortality. There's a built-in problem there. If you take all-cause mortality, let us say after the COVID, 1,000 people more died of COVID disease. It doesn't matter whether they had mammogram or not. That's going to adversely contaminate the data. So most studies in the past have been focusing on all-cause mortality. Now studies are redefining, and hopefully in the next few years we may be able to pinpoint was it related to the cancer. It's going to be a Herculean task, especially because Dr. Pramesh made the point, only 10% of the cancers are registered in India, which means 90% are not registered anywhere. Cause of mortality, cause of death is equally challenging. I was talking to Dr. Pimble, Dr. Sharmila Pimble, and she said that's even more challenging. You cannot trust many of the death reports or death certificates. So there's a long way before we can put any confidence on the data which we have in India for 140 crore people. So coming to the methods of cancer screening, breast self-examination is encouraged for women to come to know about their breast more, and if there is a deviation, to bring it to the attention of health professionals. But so far, it has not shown that it would improve their lifespan. In other words, it does not reduce the mortality. There's an interesting study which came from Tata Memorial Hospital, Indranil Mitra and his group, 3 years ago, which showed that clinical breast examination is a different story. The Tata Memorial Hospital got about 150,000 patients, split them into two. 75,000 of them were screened by people who are trained to do clinical breast examination, and the other half didn't have clinical breast examination and close follow-up. Clinical breast examination is by a trained staff, not by the patient. And interestingly, there was an improvement in early detection and also a remarkable decline in mortality. So that's a very good study. In fact, it was quoted as one of the best studies internationally, and I think many journals wrote an editorial on that. So I was so happy to see that it came from Tata Memorial Hospital, from our country, that clinical breast examination by trained staff can make a difference. These equipments are available in United States through the National Cancer Institute. They are silicon models, and we requested an entrepreneur in India, can he donate that? Thankfully, he agreed, and I have brought them here. I just handed it over to Father Kudarathal and also to Dr. Sarah Isho. Those models will be kept here. When you go out into the community, you can train some of our volunteers or even nursing staff or technicians how to do a clinical breast examination using your palm. These silicon models will teach you how to pick up fibrocystic disease, how to pick up a lipoma, which is basically a harmless tumor, how to suspect a tumor, how to do a nipple examination. So the models are right here. We handed it over to Dr. Sarah Yeshu today. It's available in KM and we have institute and we have already offered to other hospitals. They can come and borrow it from us for population studies. The most important thing is the mammograms. And mammograms are, we discussed about when to do it and how to do it. The important thing to know about the mammogram is that the American Cancer Society data did about 287,000 women with invasive breast cancer, of which the mammogram, this is the data from, even in spite of doing the mammogram, about 48,250 died of breast cancer in 2022. But when they went back, they found that from 1981 to 2021, there's a 42% decline in mortality from breast cancer. And so they were thrilled to see that this mortality was brought down by screening mammogram in one end, creating awareness in the other end, and of course, the dramatic improvement and revolutionary changes in the treatment of breast cancer. And that's what happened in USA. Coming to India, of course, we don't have to be depressed or dejected. The GloboCan data shows that our incidents were 18,000, and we have a 39.1% increase in 26 years. Actually, it could be much more than that, but at least this is the published data. So comparing to the Western population, there seems to be ever increasing incidence, and we may have to include clinical breast examination and screening mammogram by the modern techniques. And the chart shows how the success story of USA can be projected onto a graph. Unfortunately, the success story is not reflected in the Black American population. Generally speaking, the Black American women, the incidence is much less when compared to the white. But when it comes, it acts ferociously. The Black women develop the most lethal form of breast cancer on many occasions. The Asian are somewhere between the white American population and the Black women. The Hispanic and the African, Asian Pacific women have the worst. And the reasons are self-explanatory, because they don't come for screening, they don't, their awareness is low, and invariably their insurance coverage is so poor that they don't come for the mammogram either. So the current methods of screening, breast self-examination, I told you it doesn't influence your mortality. Clinical breast examination, the Westerners didn't have much trust in that, but Tata Memorial showed this excellent study, more than 150,000 persons screened into two halves, and showed that there is an improvement in survival. So that's something which we can incorporate in our system of breast cancer screening. And then the screening mammogram, we'll talk about that very shortly. The goal of screening is mainly to detect preclinical. Preclinical means before it comes to the surface, you want to pick it up. Or it could also improve survival. The earlier you diagnose, the better for you. It decreases the cost, because it's better to take out a 1 centimeter lump than to wait for a 5 centimeter mass which has gone to the axillary lymph nodes. So the cost will be down, and it also decreases more invasive treatment. The scare and stigma is because you go for these advanced lesions, have an axillary lymph node dissection, develop the lymphedema, so it becomes a scary disease, not if you pick it up early enough. And that's the whole purpose of screening. Now, these guidelines have been endorsed by different societies, the US Public Service Task Force, the American Cancer Society, the NCCN, American College of Obstetrics and Gynecology, American College of Radiology. Why there is a difference of opinion is again due to the lack of agreement on when to screen, how often should be screened. But it looks like everybody is in agreement that past the age of 45, you should have screening mammogram, and the frequency can be reduced to once in 2 years, except, and this is a very important statement, except in people with a family history, where you don't want to wait for 2 years. and also except in people with what appeared to be a malignant lesion before it was excised, and also in people who have high risk like radiation below the age of 30, radiation to the chest, a well-known carcinogen. So family history of breast cancer and past history of radiation to the chest below the age of 30, and also any hormonal treatment and any previous biopsy of suspicious lesions will put you into a group which need to be screened every year. The effect of screening mammography, importance of the denominator. This is where the controversy comes. It's great if you can bring down the mortality, but have you really done that in a huge population, or are you doing that in a group of people who were screened? If you take the population who underwent the screening, yes, it probably has a 20%, 25% reduction in mortality. But we never did that in a population as a whole. What they are trying to say is that if you don't do a complete study in Alapi district or Pathanamthitta or Idukki district, you may get an unscreened population, and there the cancer is appear to be, death is appearing to be almost equal. Whereas if you screen the population, then also more cancers are detected and the death may be reduced. This is a false clue according to the critics of mammogram. For what they are saying is, if you really want to get the best out of this mammogram, do population studies. And that is precisely what KM Cherian Institute will be looking at in the next 5 to 10 years. We may be moving into Idukki, Pathanamthitta, Alappuzha, Kottayam district and see if we can get population screened. And fortunately, many private organizations are offering funds for that. Now, technique of breast screening imaging, it's very simple. You all know this. I don't have to spend much time here. Two types of mammogram is screening mammogram, where you catch a 45-year-old lady doesn't have any problem, but we want to check if she has any lesion, or diagnostic mammogram, which means the ladies felt something abnormal, like a nipple discharge. So that's a diagnostic mammogram. Then we have other techniques also, the ultrasound of the breast, the MRI of the breast, and new technique of molecular breast imaging is basically using radioactive tracer and using a special camera. Very important in after resecting a suspicious lesion. We want to know if all the lesion has come out, and that's where the molecular breast imaging is being tested. Now, shared decision making. Please keep this word in the heart of heart. Shared decision making is going to be a challenge in a civilized society. You will have to sit down with the patient and discuss the pros and cons of all these treatments. For example, a 75-year-old woman may be coming to you and they may be saying that I used to have the screening mammogram every 2 years. Now my doctor says you don't need it. So that's where a shared decision making is important. Your chances of having an invasive breast cancer are substantially less. So after the age of 75, you could even avoid screening mammogram. Last week from Nevada, there is a study that new molecular screening can confirm a group of women with less than 7% risk, less than 7%. And they could even forfeit mammogram. This is a retrospective study. Before it is going to be adopted as the mainstream policy, it has to be done in a prospective study. But the way things are going, we are going to stratify who needs to be screened, how often needs to be screened, and what type of methodology should we follow. Now, why is it that there is so much of criticism against mammogram? We may keep in mind, because all of you will be asked this question by your neighbor, your friend's wife, or your colleague's mother. The main reason is 61% of mammograms in USA were false positive. There was a red signal, but when you went in and took it out, it didn't contain cancer. There is also this overdiagnosis. There are certain lesions which can stay there for years together before it turns malignant. So you are taking out a relatively indolent lesion due to overdiagnosis and overtreatment. Radiation, we touched upon that. The amount of radiation that the patient gets is a matter of concern. There is something called lead time bias. What it means is a time from a mammogram abnormality to clinical detection. For example, we went to Idiki and we picked up through mammogram, some lesions in February 2024. Probably that lesion wouldn't cause any disease for the next 5 years. So if you are going to add this mammographically detected lesion to the total data, you're going to add another 5 years. So you can say it was good because mammogram was done in 2024, whereas this lesion wouldn't have caused any problem until 2030 or 2035. So you get an added 5-year advantage by doing that. Is a lead time bias. The length time bias is what we already know. Screening mammogram may pick up more slow growing tumors and identify a subgroup which can falsely lead you to the benefit of screening mammogram. All these are challenged because these screening mammograms were done in 1960 to 1980, when the technique was not as smart as what we have today. So many experts challenge these comments, and the consensus is that it's better that you start your mammogram around the age of 40 and then continue at least every 2 years, but definitely for women above the age of 50, a 2-year interval is allowed, but between 40 and 45, especially with a family history of first degree relative or previous biopsy of a lesion or previous radiation of the chest, they may like to do it every year. This is the shared decision making. The patient, the family, and the doctor participate in the decision making. This is one of the big challenges we may face. Dense breast, it is not a physical examination finding, it's a radiological diagnosis. What are the diagnostic challenges? On the left side, you can see a normal mammogram. On the right side, you can see the mammogram of a dense breast. In dense breast, what happens is the fibroglandular tissue is so much proliferated, it causes a white patch. The two reasons why we worry about this. One, this may be masking a small lesion in the breast. Second thing is, studies have shown that if you have a dense breast, your chances of developing an invasive breast cancer are high. That has been proven. Most of the dense breast happen after the age of 50, like something like 6 to 7% in Caucasian population. But our story may be different. We will find out when we start doing this test in Kerala. If there is dense breast, the best way to screen the mammogram would be a 3D, what we call as breast tomosynthesis or 3D mammogram. Fortunately, many private hospitals in Kerala have 3D mammogram. I just made an inquiry, how much does it cost? And I even asked the health minister. She said at Cochin Cancer Center, where 3D mammograms are available, the cost is about 1,500 rupees. Private hospitals are now charging about 3,000 to 3,500, but the cost will come down if more and more people start using it. So the 3D mammogram is available in Kerala. If you have a patient with a dense breast, which means the fibroglandular tissue is more prominent than the adipose tissue, then that patient is a candidate for 3D mammogram. Now when you say dense breast, it doesn't mean the fat in the breast. It doesn't mean the firmness in the breast. It's a radiological diagnosis. Keep in mind. So dense breast and diagnostic challenges. We already touched upon the fibroglandular content of the dense breast, and women with breast dense have a high risk of cancer and difficult to detect cancer in routine mammo. And this is basically what we would like to know. The glandular and lobular cells and the ductal cells are the ones which proliferate and give you the dense breast. Category A, the breasts are almost all fatty tissue. That's the normal mammogram. But you can see category B, that white streaks are scattered areas of dense glandular and fibrous tissue seen as a white area in the mammogram. If that is huge and more extensive, then that woman has a dense mammogram. Okay, let's see. So where do we stop now? Mammogram recommendations are constantly changing, and that's because we are incorporating better methods of screening them. Consensus is more important. Shared decision making is more important. Unless we move into the community and do population studies, we may not be able to accurately find out the incidence, the prevalence, and the mortality. And hopefully, when the Pamba starts flowing again, just like and quiet flows the Don River, we will enter into a phase of the development of KMCHR Institute of Medical Science, where this institute is going to make a big impression on the population health of the people in the eastern districts of Kerala, a relatively neglected area. And that may be the day when National Cancer Grid and Dr. C.S. Pramesh would declare, yes, the KMCHR Institute of Medical Science has arrived. Thank you for your attention.
Ladies and gentlemen, let's take a moment to express our heartfelt thanks to Dr. M.V. Pillai sir for the incredibly insightful and engaging presentation. We are truly grateful for the wealth of knowledge shared with us today. Now, may I invite our Managing Director, Reverend Father Dr. Alexander Kudarathil, to hand over the memento to Dr. M.V. Pillai sir. Thank you, sir. Thank you, Acha.
Now we break for tea. Tea has been served on both the sides. Please come back for the continuation of the session in around 10 minutes. Thank you. For the dignitaries, the tea will be served
With a 300-plus bedded inpatient department, including royal suite rooms, we bring global healthcare standards closer to home. Here, life begins and dreams take flight with a personalized care and seamless attention. Widening our borders to the rest of the world, Dr. K.M. Cherian Institute of Medical Sciences is opening an international hub for quality medical services. Ensuring the best healthcare for you and your loved ones, we have installed state-of-the-art technology supported by well-trained professionals. With you at the apex of our functioning, we continuously improve clinical procedures and service quality. Frequently training our team in all the growing changes in different medical branches, Dr. K.M. Cherian Institute of Medical Sciences works towards efficient early cure for our patients. Making a whole bouquet of services easily accessible by all, we are committed to the betterment of our patients' lives. Provisioning the best quality products in medical cure and remedies, providing nourishment and wellness for the body and the mind, serving love and healing together. We keep your health at the center of our service. We keep your happiness at the center of our hearts. And we keep striving to ignite the flame of hope in quality healthcare services.
Dr. K.M. Cherian Institute of Medical Science, Kalliseri, Chenganur, is a private limited company. Sri P.M. Sebastian, UAE-based industrialist and medical entrepreneur, is the chairman of this hospital. World-renowned cardiothoracic surgeon Dr. K.M. Cherian is one of the directors and also the head of cardiothoracic and vascular department. Mr. Sibin Sebastian is the vice chairman and Mrs. Sheila Philippos is the deputy chairperson. Other than 14 board of members are here in this private limited company. We are developing project that is called ARA, Analysis, Research and Academic. Under this project, we have conducted 2 international conferences. More than thousands of doctors participated in these 2 conferences. Another hero of the wing is ATPP, Accident Treatment Program with public support. We have conducted training program for police officers and exit staff. More than 1,000 police officers and exit staff of Alappuzha district and Pathanamthitta districts participate in this program. And also training for the drivers of ambulance, taxi, auto rickshaw. We are the frontiers for the society for giving better treatment and help.
Dr. K.M. Cherian Institute of Medical Sciences, a new hope in healthcare.
Dr. K.M. Cherian Institute of Medical Sciences, Kallisheri, Chenganur, a world-class hospital you can trust.
The language of healthcare extends beyond prescriptions and procedures. It is the service of imprinting a patient's mind with a new and renewed hope for life. We at Dr. K.M. Cherian Institute of Medical Sciences have always kept this at the center of our vision. Serving and supporting our community with humanity and equality. This fulfilling journey in the path of healthcare under the guidance of our founders and forerunners began.
Dr. K.M. Cherian Institute of Medical Sciences, Kallisheri, Chenganur, a world-class hospital you can trust.
In the year 2021. Since then, every day poses us with newer challenges and our expert team is always ready to give their best. Hundreds of patients experience services from the region's best doctors and leaders in their specialties spread within 30 departments. Proper and precise diagnosis leading to immediate responses to the cause ensures minimal complications and a highly efficient pattern of treatment. With a 300-plus bedded inpatient department, including royal suite rooms, we bring global healthcare standards closer to home. Here, life begins and dreams take flight with a personalized care and seamless attention. Widening our borders to the rest of the world, Dr. K.M. Cherian Institute of Medical Sciences is opening an international hub for quality medical services. Ensuring the best healthcare for you and your
Request
loved
everyone
ones.
to please be
We have
seated
installed state-of-the-art
so that we can
technology
continue with our talks.
supported by well-trained professionals. With you at the apex of our functioning, we continuously improve clinical procedures and
Kindly request everyone to please be seated so that we can continue with our talks. Kindly request everyone to please be seated. We are moving on to the next session.
We will start with our next session. Next, we have a talk on integrating palliative care with oncology treatment by Padma Shri Dr. M.R. Rajagopal. Dr. Rajagopal is the director of the WHO Collaborating Center at Trivandrum, the chairman emeritus of Pallium India and adjunct professor of global oncology, Queen's University, Canada. His initiatives to remove regulatory barriers in availability of oral morphine for pain relief have contributed to the amendment of the NDPS Act of India in 2014, a government policy on palliative care in the state of Kerala in 2008, and Government of India's National Program for Palliative Care in 2012. The international organization Human Rights Watch honored him with Alison Days Forges Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic 18 Experiments in Gently Shaking the World based on Dr. Rajagopal's contribution to palliative care, was released by the Moonshine Agency, Australia. He was named one of the 30 most influential leaders in hospice and palliative medicine by American Academy of Hospice and Palliative Medicine in 2017. In 2018, Dr. Rajagopal was honored with the Padma Shri. I welcome you, sir, to the stage for the talk.
Thank you very much. Thank you very much for the honor, and very, very happy to be part of something great evolving. I can see it in front of my eyes, and it's not something that's going to happen a long time away. It's going to happen now. So, Sarah and all colleagues, Sacho, thank you for the opportunity to be part of it. I am here. As of course I am a doctor, I am a healthcare provider, but I am also standing here as a potential patient tomorrow. I am what is called TAB, temporarily able-bodied. That's borrowed phrase from Dr. Chochinov. I have only 10% chance of dying a sudden death. I have a 10% chance of dying with cancer, like everybody else. I am not afraid of death, but I am afraid of the dying process. I am afraid of dying process in the hands of the medical system today. I am afraid of living with the disease in the hands of the medical process today. I am glad I had the opportunity to be in palliative care, to walk along people who are living with the disease. My worry is that when my time comes, the system will be treating my body. As a rather famous Dr. Eric Cassell said, it is persons that suffer, not bodies. It's persons that suffer, not bodies. My medical education, my post-graduation, everything was centered on the body. The cells, the microbes, the tumors, the organs, the chemistry. Where was the education about a human being? If it is the person that suffers, who will look after me? Thank you. The cancer oncology department here is going to look after not only my tumor, but also me, the person. For which palliative care needs to be integrated to oncology care, not something to be done only in a clinic in a corner of the hospital, but something that is to be practiced as part of healthcare delivery. It's not only a personal opinion, it is what the World Health Assembly. The World Health Assembly is the decision-making body of World Health Organization. In 2014, they came out with this recommendation to integrate palliative care into healthcare at all levels. Primary, secondary, tertiary. There should be a tertiary center, of course. It's needed here, but also at the secondary and primary levels. Across the continuum of the illness, from the diagnosis to the end. Wait a minute. Those of you who have heard about palliative care, do you have some sort of a feeling that it is only for cancer? It's not. It's for any serious health-related suffering. Do you have a feeling that it is only for the dying? It is not. See, it is across the continuum of care. For example, much was talked about the early diagnosis. Dr. M.E. Pillai talked about the value of, Dr. Pramesh talked about the earth shot, and Dr. M.E. Pillai's earth shot was the clinical breast examination. So what happens when the diagnosis is made? Dr. Pramesh, I saw this video, that was the early days. We're following that national program for a sample to be taken in Kolkata and it is to be diagnosis made by Mumbai. And somebody is in that rural Kolkata area is diagnosed with cancer, and then what happens? The video showed a phone call to the person. हेलो कौन बात कर रहे हैं? सो एंड सो. ओके, सुनिए, आपका रिजल्ट तैयार है, आपको कैंसर है. Imagine the plight of somebody. Okay, somebody came and took a sample, and all of a sudden, like a bombshell, being told, you have cancer. Why am I saying this here? Palliative care integration at that level would mean that the person who makes the call, once that integration happens, will realize that the person at the other end of the line is not only a container of cancer, it's a human being with emotions, with all a human being's weaknesses, fears, anxieties. And that bombshell means what the person has thought about cancer. Maybe the person is not thinking about a possibly curable illness. The person is thinking possibly in that mind, my God, I am done. My children will be orphans. I will be suffering. I will be crawling around like my uncle who died at one time with maggots all over his wounds. That's what the person will feel. When I say integrate palliative care, I mean, remember that palliative care, no long definitions. If tomorrow somebody asks you what's palliative care, just say it is mitigation, it is management of serious health-related suffering. Management of serious health-related suffering. That suffering can start at the time of the diagnosis, when somebody tells you, "Aapko cancer hai." And from that time, at every stage, this palliative care is necessary. Does that mean that every patient has to be referred to the palliative care clinic? No. That happens when there are oncologists like these who understand human beings, who understand that palliative care has to be given from the time of diagnosis to the end by every clinician, not only the oncologist, every doctor in the hospital, every nurse, every social worker, whoever is dealing with the patient. In 2017, there was a Lancet Commission which published its report on access to palliative care globally. After its publication, Dr. Richard Horton, the chief editor of the Lancet Group of Publications, wrote an editorial, and he said, medicine can never be the same again, because this report, in effect, shifted the focus of medicine from diseases to suffering. Well, nobody is saying that the disease is not important. Oh my God, of course I want my disease treated. But it shifted the focus from a total concentration on a tumor or a microbe to a human being and suffering. Serious health-related suffering is the focus of healthcare as much as the disease. And by the way, in our country, the doctors or healthcare providers' duty of care is not defined by law. In many countries, it is defined by law. In our country, a statutory body of the government of India, that is the Indian Council of Medical Research, its bioethics unit, has defined it. Same thing. It is to mitigate suffering, cure sometimes, relieve often, and to comfort always. But mitigate suffering, there exists no exception to this rule. This is from a statutory body of our government. So, when we talk about this integration, of palliative care into healthcare. In the context of cancer, I will mention two important parts. One is what we talked about, oncology practice from diagnosis to treatment. And the other is its role in critical care. I started by talking about myself as a patient. I am continuing to do that. I am particularly thinking of my last few days. That integration means everybody treating me would see me as a person. Now, this is difficult. Seeing me is very difficult for healthcare providers because you are concentrated so much on the imaging. You will be looking at the file, at the screen, at this and the computer screen, and you will forget me, I am afraid. A former editor of New York Times, all of a sudden I can't remember his name, from his deathbed, he wrote a series of articles. One of them says, "Doctor, talk to me." And in which he says something like, doctors, I know you are busy, you don't have a lot of time, but when you have 1 minute, he says, sit down beside me. This sitting down is very difficult and very important. You will find time for everything else, but then most of the time, somebody will look down at me and talk to me. But when that person sits down beside me for that just 1 minute, I feel somebody cares for me. And so this man says, "Doctor, talk to me." He says, for that minute, please sit beside me, look me in the eye, listen to me and talk to me. So, as when we talk about integration of palliative care, every healthcare provider's work, starting from the security staff, who is the person I am likely to see first. I hope to see compassion in the eye. I hope to see the recognition that a human being in suffering is before them, and that is being present for me. And also, suppose then that person says, "I see you are a bit anxious." I don't want any false reassurances. If you say everything is going to be okay, I won't believe you. I know everything is not going to be okay. But if you say, "I think you are anxious," do you want to tell me about it? Don't make assumptions. Assume is not good. As plus you plus me. Not acceptable. Instead of that, ask me. Do you have any questions? Are you anxious about something? And that makes wonders. I will feel, oh my God, I have come up before a human being, not a medical machine. And then I will feel this person will care for me. And I will have 100 questions in me. Please answer at least a couple this time. And give me some opportunity to ask this question to somebody else. I know of one of the excellent hospitals where there is one nurse given the task of talking to patients and giving explanations about the treatment protocol. Doctors, of course, understandable. Like our mutual friend Dr. Christopher Booth has written an article in which he compares the workload of Dr. C.S. Pramesh and Christopher Booth. He has to see at a minimum 15 times as many patients as Chris does. So I know there is no time. The nurse starts, listen to me, don't ask any questions, because then she doesn't have time. 1, 2, 3, 4, all the facts are given as if there is a computer there. The person who is so anxious has to take in all the information and remember all that. If that person could remember all that, they would have been in the other chair. So this information need is vitally important. Please answer my questions when I have questions. And tomorrow I will have more questions. If there is a telephone line where I can pick up the phone and ask questions, that would be wonderful. Generally, we all know India has some of the best hospitals. Esther is a Kenyan doctor. She brought her aunt for a 1 week treatment in an Indian hospital. And when she went back, she wrote this: "You have the best of everything. Why don't you treat pain?" That's my main point. Not only information needs. I am allergic to pain. I don't like it. You may consider it doesn't matter. My tumor matters, my pain doesn't matter. But as Esther says, why don't you treat pain? Pain is suffering. Again, not only by a palliative care doctor, but by every clinician, pain is taken as important. There was an international conference on tourism in New Delhi, at which the head mentioned two things that have to improve in India. If health tourism is to be top, everything else is great, he says, but we need better hospitality and up to the mark palliative care. Suffering also needs to be treated, and that is unfortunately not happening in India. Some kind of palliative care reaches less than 4% of the needy in India. I know Kerala is 15 times better, so 15 or 16 times better, but nowhere near enough. And this is what this institution is going to do. Thank you for creating this place with the integration of palliative care right from the beginning. My organization, Pallium India, worked with two hospitals. One is Dr. Ravi Kannan's Catcher Cancer Center in Silchar, Assam. The other was the Himalayan Institute in Dehradun. These two hospitals, one is a cancer hospital, other has a cancer division. That cancer division and Ravi's hospital became pain-free hospitals. Well, don't take that too literally. No hospital can be totally pain-free, but what it means that in those hospitals, every single nurse and every single doctor went through some basic course in pain management. And every month there is a review session. That's not all. 2 doctors and 2 nurses in the hospital got additional training over 6 weeks of hands-on training as consultant doctor and consultant nurse, and 2 nurses continue to work as full-time paid nurses. I hope something like that will be possible here. What they do is, of course, every patient is asked, do you have pain? If so, they are asked to score it on a scale. And this, in every inpatient has the question asked every day. Every doctor has been trained in pain management, so they treat the pain. And if they cannot treat it adequately, a palliative care doctor comes in. The 2 nurses do ward rounds, sampling patients, random sampling among inpatients to make sure that is somebody left out. Now this worked wonders. This has given the results, the pain scores, the burden of suffering in your hospital in front of your eyes coming down, and patients naturally happier with the treatment. Now, the National Cancer Grid, the organization that Dr. Pramesh leads, has, we had the opportunity to work with them and has created a tool. This is something that I hope we'll be able to do, where you will need a couple of social workers or nurses dedicated to this, where every patient is asked not only whether you have pain, this is taking one step further, screening everybody for suffering. That detailed questionnaire is there. It's not readable, I know. I only wanted to show you that one questionnaire is available. Those 5 questions are asked to look for pain or other symptoms, to see major anxiety, depression or other emotional factors, major social issues, including relationships like, you will be amazed how many women with cancer are abandoned by their husbands and sometimes by their families. Major social issues, including financial issues, spiritual issues, not necessarily related to religion or God, but also, oh, ഞാൻ ഇനി ജീവിച്ചിരുന്നിട്ട് എന്താ കാര്യം? The feeling of futility, no purpose in life, no meaning in life, abandonment, all that, and financial issues. Dr. Aju Matthew and colleagues recently published a paper where they found that 51% of all cancer treatment among the study in 3 states, 51% had catastrophic health expenditure. That means, what it means is that the next generation is also going to suffer. Their education is stopped. So, I hope we'll be able to build this system where everybody is asked this. Major issues are identified. I know we will not get everything by this screening, especially on the first day. But we will get some, and we'll be able to address that. That was the first point about integrating palliative care into all oncology practice. But the second point is about critical care. My pet fear. I'm an anesthetist. I have been an intensivist for a long time. I have done intensive care. I know what intensive care is. I know that it can miraculously save lives. You know what is special about intensive care? Every single organ function is studied, not on a daily round, minute to minute. If my cardiac output drops, the screen shows it, and before it impacts my other organs, including the kidney, the team can intervene. So in critical illness, it can dramatically save lives. Thank you very much. I want my life saved if I have such a critical illness. But if you are offering it to me as a resort for the dying, thank you very much, I don't want it. I know it is air conditioned. I know that you have the temperature something like this, where at that time I am like to be shivering all the time. Very comfortable. There is even sometimes one-to-one nursing also. But is that what I would want? Some of you will not be afraid to think about your own death. Those who are not afraid to think about, all the others, I wish you immortality. But those who are not afraid to think about death, where would you like to be at that time? My greatest need at that time may be to get a kiss on the cheek from my grandchild. Show me the intensive care unit that will permit it. I want a hand to hold when I am afraid. And if a finger will come up to wipe my tear, I know that somebody cares. All the important things will be systematically stolen from me when I am dying in an ICU. This is a new disease, intensive careopathy, that happened only in the last 25 years. Till the end of 1990s, it was not like that. Intensive care was for people whose lives could be salvaged. Now intensive care is a place where death is made as brutal as possible. Physical suffering, emotional suffering, social suffering, which is stretched out. The death that I would have died in a day is stretched out over 3 weeks. End of life care has to be made humane. Dr. Sankha Mitra is a British oncologist of Bengali origin, and he says in India, he does charity work in the Northeast. We work closely with him. He says that in India, the poor die in misery of neglect, the middle class die in misery of ignorance, lucky people. The rich die in misery on ventilators. No one gets a pain-free and dignified death. This is one of the things that I hope we'll be able to change together. There is no justification for this. And particularly, this disease of intensive careopathy is Indian. I have data here. See the first panel. This is from European Union countries, published only 4 years back. Fairly recent data, that's what I mean. 90, it's 89 point something % of people on intensive care, when treatment was considered futile, when return of life to reasonable quality of life was not considered possible, 90% were taken off ventilator and instead given palliative care, compassionate care. See the data for India. The other panel, again, recent paper, only 3 years old. Dr. Rajkumar Mani is maybe the most respected critical care physician in the country. And he and his colleagues found this, did this study where he found that 70% of people, even when treatment was considered, 70% of people who died in an ICU had been continued on the artificial life support systems till the last moment. Why? That is not standard practice. And the 30% who were taken off ventilators did not get palliative care, and they died quicker but horrible deaths too. This is one of the things that Dr. Pramesh's Choosing Wisely India document came out with 10 recommendations, and one of them is, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. And this, hopefully in another 10 days, is something that we hope to work together in Mumbai to create some practical action plans for implementation of this in cancer hospitals. One of the major problems is you cannot take somebody off a ventilator really efficiently unless you can instead give palliative care there. We don't want the person to suffer from acute breathlessness at that time. So that has to come in, and this is something that we will have to make happen. And sir, this is the only important thing that I hope we'll be able to do together here. And I am almost ready to finish. A couple of points. Very often there is this opiophobia, fear of morphine. We all had our education with being taught that morphine causes addiction, morphine causes respiratory depression. Both are true, but not true in the practical sense. At the appropriate dose, it doesn't cause problems. I would consider the diclofenac or brufen that you swallow to be so many more times toxic to the body. These are safe drugs if effectively given in the right dose at the right time. Particularly for breathlessness, this is something that we will have to learn to do. If somebody is breathless with a terminal disease, not necessarily cancer, even in COPD, where we were once taught that it was so totally no, this becomes a drug of choice. Small dose opioids could be the most effective medicine at this stage. And this again, I am giving the evidence here. This is a population study on 20 to 49 patients on oxygen. This low dose morphine was found to be safe even with patients with COPD, and low dose benzodiazepine and low dose morphine could be successfully combined, safely combined, to give relief to patients. I'll stop there. When we talk about humane end-of-life care, very often many problems are brought in. Some people say the families don't allow it. Families come and say, no, 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 do everything for my dad. True. Sometimes the extended family and the society mistakenly assume there can be religious objections also, because what we are recommending is euthanasia. My good God, we are not talking about killing people. We are only talking about allowing people to live to the last moment with some dignity and to die with some dignity. That's all we are saying. And because of this mistaken idea about euthanasia, which unfortunately was fueled by a Supreme Court verdict, this has got a bad name. So there can be societal objections. Legal position is more or less clear. I'll just show you it in a moment. But I truly believe, when I talk to young doctors who have recently passed out, the biggest fear is doctors' mistaken duty, sense of duty, believing that they have a duty to stretch out the dying process, to extend life. No treatise on ethics says so. Just as we have to accept life, we have to learn to accept death as the inevitable consequence of life. The Supreme Court judgment early this year, January, says the advanced medical directive that I have signed and left with my wife and my 2 children, with an instruction to take it with them when I am taken to hospital, that is legally valid now. All that I need to do is to get it signed by a gazetted officer. Earlier, complicated regulations were there, but all that have been changed this year. If I happen to be already on a ventilator, according to the court, there is a process to go through which may take up to 5 days, but that is valid only if there is a dissent. If you, my doctor, believe that the right treatment is not ventilation but instead palliative care, then this doesn't apply. There can be a conflict between my children and you, then it's a problem. So the most important part of preparation of the advanced medical directive is talking to the family and making sure that everybody is on the same page. The advanced directive form, the details about the end of life care policies, etc., are on our website. Anybody who thinks in those lines of preparing an advanced medical directive or a living will, please download a format, customize it to suit yourself, and get it signed by a gazetted officer after discussing it with your family and getting everybody's consent. So those are the 2 things that I had to say. One, about the whole of healthcare, in this case cancer care, incorporating principles of palliative care into it, including physical, social, emotional and spiritual well-being, and about making the dying process compassionate. Thank you very much.
Thank you, sir, for your insights into palliative care and reminding how a human touch is needed right from breaking the news and further during their care. And also enlightening how medicine is not just explaining your protocols to your patients, but also listening and talking to them. Now I invite Dr. Sunil Agarwal, Senior Consultant CTVS Surgeon, KM Hospital, to present the memento to Dr. Rajagopal. Thank you, sir.
Our next speaker holds a special place in the heart of our institution as not only an esteemed faculty member, but also a guiding force in the setting up of the oncology division. It is indeed a great honor to call upon Dr. Sara Isho, Medical Director, Oncology Center, KMC Hospital, for the next talk on therapeutic advances in the management of breast cancer. Dr. Sara Isho is a hematologist and medical oncologist who has been working at the Robert Wood Johnson Barnabas Health Medical Group affiliated with Rutgers University in New Jersey. Now she has joined Kemcharian Institute of Medical Sciences in Chenganur as the medical director of the Oncology Center and consultant oncologist. She is triple boarded by the American Board of Internal Medicine, Hematology and Oncology. She has served as the Chief of Hematology and Oncology and Director of the Cancer Services at her institution in New Jersey. She had founded Ocean Hematology and Oncology, a center for cancer and blood disorders, in 2006. Her center was well known for providing compassionate cancer care in Ocean County, New Jersey. Dr. Sara has a passion for raising awareness about cancer prevention and screening among the general public. She has organized many seminars for this purpose. Her medical school training was at Kottayam Medical College and her fellowship was at New York Medical College in Valhalla, New York. An avid writer, Dr. Sara Isho is also the literary editor and frequent columnist for Janani, a monthly Malayalam magazine, and has published a collection of essays in Malayalam. Over to you, ma'am.
Thank you very much for that very nice introduction. Respected guests, distinguished speakers, and my dear friends. I have a very tough job now because I have to follow these excellent presentations from these legends. I'm really humbled and honored to be here today to be talking to you about advances in the treatment of breast cancer. We have a mixed audience here. We have some oncologists here. We have other physicians who are non-oncologists and from various other fields. And we have a few non-physicians and non-healthcare professionals. So if my talk is going to be simple for the oncologists or those who work in the oncology field, I really apologize for that. So why did we choose breast cancer today? As we saw earlier, breast cancer is the #1 cause of cancer worldwide. About 2.3 million new cases were diagnosed in 2020 worldwide. And the future burden is predicted to increase over 3 million, and 1 million deaths are supposed to happen by the year 2040. So when you look at the global statistics, breast cancer accounts for about 24% of all cancers. And when you look at the statistics in India, breast cancer is also now the most common cancer, and it has surpassed cancer of the cervix and oral cavity. And the one thing to remember is that in India, compared to the West, compared to the Western countries, a higher proportion of breast cancer patients tend to be premenopausal. Between the age of 40 and 50 is the peak age. And another comparison is that the incidence of breast cancer is rising globally, but mortality from breast cancer is declining, as we saw earlier in the United States and other Western countries. However, breast cancer deaths are increasing in India. And most of the time, the stage and diagnosis is well advanced in India compared to the Western population. So when we talk about the advances in treatment, to talk about breast cancer treatment, you actually need like a full week of conferences to touch upon every single aspect of breast cancer treatment. So from this 30 minutes, I'm just going to touch upon some of the recent advances and in breast cancer treatment. So when a person is diagnosed with breast cancer, there are 3 modalities of treatment that are offered to that patient. The mainstay is surgery, and the second one is radiation therapy, and the third one is systemic therapy, therapy that's given either by mouth or by intravenous. So that can be either endocrine therapy, chemotherapy, and most recently targeted treatment or immunotherapy. So breast cancer surgery has evolved a lot in the last several decades. I'm not a surgeon, but if you look at the picture on the Halsted procedure, for those who are in the medical field, we have learned about that in our medical education. But I don't think we see this kind of surgical scars anymore. The radical mastectomy that was done in the 1800s and early 1900s used to remove the breast itself along with the tumor and part of the chest wall muscles. So it was a very radical surgery, and the scar seems to be quite big. And that kind of surgery is never seen anymore because of the advances that has happened in breast cancer surgery. We went to modified radical mastectomy where muscles were kept and the breast was removed. And now we are going towards breast conserving surgery, where the most women with breast cancer can save their breast by doing a lumpectomy or removing the tumor by itself along with the normal surrounding tissue. Some women may still need a mastectomy, which is removal of the breast, but most women who are diagnosed in an early stage in this day and age are able to spare their breasts by doing a breast conserving surgery. Another part of breast cancer surgery is removing the lymph nodes from under the arms. So when it used to be that we used to do what we call as an axillary dissection, where all the lymph nodes draining from that particular breast were removed. A downside to that axillary dissection was that women used to develop lymphedema by blocking the lymphatic zone of that side. So lymphedema from breast cancer treatment causes a lot of mortality to, a lot of morbidity to patients. If you see in the picture, the arms are being swollen, and it causes a lot of difficulty in movement of that arm. But studies have shown that in patients who have early stage breast cancer, if you just remove those 2 or 3 lymph nodes that are draining from the tumor, those lymph nodes are called the sentinel lymph nodes. So the tumor is removed, and around the tumor a dye or a radioactive substance is injected, and we identify the lymph nodes that are draining from that tumor. And if you remove just those lymph nodes and find out if they have cancer in them, that would be enough rather than doing a full axillary dissection in most women who present with a clinically negative axilla. So this is a landmark study called the C11 trial, where early stage breast cancer patients underwent breast conserving treatment and sentinel lymph node biopsy, and those who had a positive sentinel lymph node were compared to doing a full axillary dissection versus sentinel lymph node biopsy. And the outcome was that the 10-year survival for these women, for those who underwent axillary dissection versus those who only had a sentinel lymph node removed, it was similar. So we realized that you don't need to do a full axillary dissection, you can just go by a sentinel lymph node biopsy in these women. So if you look at the overall survival and disease-free survival in these 2 arms, it looks similar. So in a nutshell, if we talk about breast cancer surgery, we have come a long way from Halsted's radical mastectomy to modified radical mastectomy to simple mastectomy, and now by breast conserving surgery. So the bottom line is in surgery nowadays is less is more. So now only very few percentage of women would actually need a mastectomy. Those who have multicentric disease, multiple areas of the same breast affected with cancer, or if the tumor is larger compared to the size of the breast, or there are abnormal imaging studies showing a diffuse appearance on mammograms with calcifications, or if you have previously been radiated to that chest wall, or if you're pregnant because you're not able to do radiation when you're pregnant, or if there is persistently positive margins after doing multiple attempts at re-excision. So these are the only indications where a mastectomy is truly indicated in somebody who has breast cancer. Now, you're diagnosed with breast cancer, and what's next? So we are talking about early stage breast cancer, somebody who had already underwent the definitive surgery. So there is still a risk of cancer coming back, either in the breast itself or in other parts of the body. So who gets this recurrence, or we call as metastasis. This prognosis is based on several factors. Number one is the stage. We stage breast cancer by the TNM classification based on tumor size, number of lymph nodes involved, and presence of metastasis. So stage is important. Then the number of lymph nodes are involved are as important. If you have several lymph nodes with cancer, your risk of cancer coming back is high. And another important factor is hormone receptor status on the surface of the cancer cells. If you or your loved ones had breast cancer and you had a biopsy, the first thing to ask is, what are the receptor status? Is the tumor is hormone receptor positive or hormone receptor negative? This can be found out by doing a study called immunohistochemistry on the tumor itself, and it can be either ER positive or PR positive or ER/PR negative. Another important factor is a receptor called HER2 or HER2 receptor, and we will come to the details of why knowing the HER2 status is important. And now we have genomic assays that will predict the risk of relapse in somebody who already had that tumor removed. So breast cancer in the 1980s and 90s was a single disease, but now in the 2000s and in the 2024, it's not a single disease. It's a disease that's different for different people. So stage by stage, breast cancer can be different based on these factors: the hormone receptor status, genomic assays, and the HER2 receptor. So there are mainly 4 or 5 different categories. If the tumor is hormone receptor positive, estrogen and progesterone receptor positive, it's called luminal A. If the tumor is estrogen receptor negative and PR positive, it's called luminal B. And if you are positive for, and in those luminal A and B, the HER2 receptors are negative. But if you are triple positive, you can be ER positive, PR positive, and HER2 positive. And then if you are, then there's HER2 enriched, where the tumor is estrogen and progesterone negative, but HER2 positive. And then there is triple negative. We heard about triple negative breast cancer, where all the markers, ER is negative, PR is negative, and HER2 is negative. And it's tends to be a more serious or more aggressive tumor, and the survival is going down when you go from luminal A to luminal B to triple negative. So the treatment is based on these factors as to what kind of treatment one person would benefit from. In hormone receptor positive breast cancer, which is the majority of breast cancer, 75% of all breast cancers expresses ER and PR, and ER negative and PR positive is extremely rare. So the hormone receptor positive tumors are generally of lower grade and most frequently seen in postmenopausal women compared to younger premenopausal women. And the risk of relapse can occur even after 5 years or even up to 20 years in patients who have hormone receptor positive breast cancer. So even after we know somebody's hormone receptor status and stage, there is another factor. There are multiple genes which can predict the risk of relapse and also the likelihood of benefit from chemotherapy. There's one such study available, is called ONCOtype-DX. It's a 21 gene assay which can predict the response to chemotherapy and also predict and see how one person would do in the long run. So it can be a high risk or a low risk based on the ONCOtype-DX testing, and we can eliminate chemotherapy in a majority of patients which we used to give chemo in the past based on this test. So we'll focus on the systemic treatment for breast cancer. We can be given in many different times. Adjuvant chemotherapy or adjuvant systemic therapy is when all the visible tumor is removed and the patient is visibly cancer free. Then they would still need treatment to reduce the risk of cancer. So this is one question we always hear from the patients. The surgeon said they removed everything, so why do I need chemo or why do I need anything else? Because there could be cancer cells that has left the cancer before it was removed, or the cancer cells in the patient's system, which can years later metastasize into other organs. So to reduce the risk of cancer after the surgery is done, the systemic therapy given for that purpose is called adjuvant chemotherapy. In some tumors, the tumors have to be shrunk down before surgery can be done. So neoadjuvant or preoperative chemotherapy or other medications are given for as a neoadjuvant therapy. Then when cancer spreads to other organs, you need systemic therapy. It's called metastatic disease. And in some situations, we use medications as a chemo prevention. So modes of systemic therapy, it can be either chemotherapy, endocrine therapy, targeted agents, and most recently immunotherapy. So in a nutshell, in an early stage breast cancer patient, all people need surgery if it can be done. So surgery is the mainstay of treatment. In hormone receptor positive, HER2 negative patients, chemotherapy is only given in high risk cases. But chemotherapy is given in HER2 positive disease and also in triple negative patients. Immunotherapy is used only in high risk patients who are triple negative. And endocrine therapy is given in patients who have hormone receptor positive disease. It does not work if you are hormone receptor negative. And HER2 directed therapy is given if you are HER2 positive. And radiation is typically given after a breast conserving surgery. So we mentioned that we can avoid mastectomy by doing breast conserving surgery, but it has to be complemented with breast radiation. So switching gears to metastatic breast cancer. So somebody presents with metastatic breast cancer, or somebody had an early stage breast cancer and the cancer spreads unfortunately after several years. It can spread to many of these organs. Mainly it can spread to the bones, or it can spread to the liver, brain, or lungs. It's called metastatic breast cancer. So the treatment approaches for metastatic breast cancer is also based on the key factors on the cell surface cells. And hormone receptor positive breast cancer, treatment is mainly based on endocrine therapy. And if you're HER2 positive, the treatment is based on HER2 directed treatment. And if you're triple positive, you can use a combination of chemotherapy and HER2 directed therapy along with endocrine therapy. And then in triple negative, the treatment is mainly chemotherapy, and in some people can benefit from immunotherapy. So targeted therapy is the new thing in oncology, and it's been around for a couple of decades. And it has really changed the landscape of oncology, and has made the lives longer and the disease better for many patients in many kind of cancers. So basically, targeted therapy is where you identify a target on the cancer cell at the molecular level, and you target it with the drug that works on that particular target, and that results in destruction of the cancer cells. So as opposed to chemotherapy, where we use it as a general treatment for the chemotherapy can affect normal cells as well, but targeted therapy mainly focuses on the targets on the surface of the cancer cells. So there are several new advances in targeted therapy in breast cancer. Endocrine therapy has advanced a lot. HER2 directed therapy has advanced a lot. The newer thing is CDK4/6 inhibitors, and then there are some mutations which can be targeted by newer drugs, and which can help to decrease the cancer volume and improve the quality of life and improve the lifespan. So if you look at the advances in the last several decades, in the 1980s, tamoxifen was the only drug that was available for the treatment of hormone receptor positive breast cancer. So tamoxifen is an anti-estrogen, and it reduces the effect of estrogen on the breast cancer cells. So as we all know, female hormones, estrogens work on breast cells to make them cancerous. So estrogen is a driving force for breast cancer. So anti-estrogens and medications that target estrogens or decrease the amount of estrogens in your body is actually beneficial in controlling breast cancer in hormone receptor positive patients. So several studies were done to see if we can improve upon tamoxifen, and in the 1990s there came a group of drugs called aromatase inhibitors. Letrozole and anastrozole are the ones that are commonly used, and it was found that letrozole and anastrozole given when they compared with tamoxifen in postmenopausal women, outcome was better in terms of improving the overall survival. So those two drugs came into approval in the 1990s. Later, it was there were more drugs in the armamentarium. Non-steroidal anti-estrogens like exemestane and fulvestrant came along. Then in the 2010 to 2014, a newer group of medicines called CDK4/6 inhibitors, they came into availability, and those studies have shown that when you add this CDK4/6 inhibitor to the backbone of the endocrine therapy like letrozole or anastrozole, women used to have a much better outcome. The disease-free survival and overall survival has improved. So several such drugs were approved in that time frame, and even now many studies are being done with this newer group of drugs called CDK4/6 inhibitors. So CDK4/6, the metastatic breast cancer, if the hormone receptor is positive, the growth of the cells are dependent on cyclin D1, and cyclin D1 activates the enzyme CDK4/6, and that increases cell division. So inhibiting the CDK4/6 will help with control of the estrogen regulated cell division. So several studies have been done, and these are some of the landmark studies that led to the approval of some of the newer CDK4/6 inhibitors. Some of you must be familiar with the name palbociclib, and another drug is ribociclib. Then there's another one called abemaciclib. 3 of these CDK4/6 inhibitors came into market almost around the same time, and they were similar in their efficacy in the initial studies, and they were different slightly by the differences in side effects. So this is one such study called Mona Lisa 3 study, where the fulvestrant and ribociclib were given in first line and second line metastatic breast cancer patients. And if you look at the line below, where only fulvestrant was given along with the placebo, and in the line above the combination was given, and the progression-free survival was significantly improved if you add ribociclib to the fulvestrant. So this is a different study where ribociclib plus endocrine therapy was given. It was compared with the chemotherapy in patients with advanced breast cancer. And we see that chemotherapy used to be the standard of treatment after endocrine therapy fails in metastatic breast cancer. But after this particular study, it shows that even chemotherapy was found to be inferior when you compare it to ribociclib and endocrine therapy together. So this CDK4/6 inhibitors differ in their side effects. I'm not going to go through the details about that. Most of them can cause diarrhea. Some of them can cause QT prolongation, and their EKGs have to be monitored. And most of them can cause neutropenia, and rarely they can cause pneumonitis. So they have to be monitored. So as general practitioners, you have to be aware of what medicines your patient is taking from your oncologist, so their other symptoms can be managed and monitored. So it used to be that patients who had metastatic breast cancer were treated with endocrine therapy by itself, and then when endocrine therapy fails, they had to go to chemotherapy. But now they have this with the newer targeted agents. The onset of chemotherapy initiation is delayed because most people can live a longer life without chemotherapy by taking 1 or 2 pills together, and they can live a relatively normal life, and even though they have metastatic breast cancer. So we have to say a couple of things about HER2 or HER2 receptor. We probably have heard this before, if those who had experience with patients with breast cancer. 15% of all breast cancer patients are considered HER2 positive, and this is due to an overexpression of the HER2 gene on the surface of the cancer cells. Normal breast cells have HER2 receptors, but when there is an abnormal proliferation of the HER2 receptors on the cancer cells, it is called HER2 positive disease. So before the advent of HER2 targeted agents, it was found that women who had HER2 positive disease had a very poor outcome. So compared to even triple negative patients, these women tend to live much less time if they were not treated with an HER2 positive, HER2 directed treatment. So studies were done to target the HER2 receptor to see if that can make an improvement in the lives of these women with HER2 positive breast cancer. So this particular study, we heard about trastuzumab from Dr. Pramesh's talk. This one is one of the studies where trastuzumab was given to patients who had HER2 positive disease, and compared to control, there's been a significant improvement in the disease recurrence and overall survival in patients with patients with early breast cancer. So this is where, very first time it was found that biology has spoken, and in the New England Journal of Medicine editorial was saying the results are simply stunning because biology has spoken and we should listen. So since then biology has been talking and we've been listening. So trastuzumab is a mainstay of treatment for patients who had breast cancer with HER2 positive disease. So I just want to go back to what Dr. Pramesh said before. Even with all the, even though the drug has been around for some time and generics are available, only 60% of women who are HER2 positive in India are able to get it, and the number one reason for that is cost. I've been looking into the costs of the drugs here. I just came from the United States, as you know, and it's been a cultural shock for me to see what is the cost of some of these drugs. And I'm humbled to see what Dr. Pramesh was saying, that you have, rather than going for the moon shots, you have to look for the earth shots. But having the HER2 directed therapy being so efficient for many women, I am just appalled by how less we can do to those patients because of cost. So that's a topic for a different talk, and we need to get into that pretty soon. So building on the trastuzumab, several different drugs came by, one called pertuzumab, another one called TDM1, and most recently this antibody drug conjugate called trastuzumab deruxtecan, which is a combination of trastuzumab which attracts to the HER2 receptor, and there is a chemotherapy link, a payload, and the medication get attached to the HER2 positive cells and get engulfed into the cancer cells, and the chemotherapy is released. So this is a very effective HER2 agent, and I'm going to go to the study called Destiny Breast 03, where this particular drug was compared to the then existing standard of care called TDM1. And I'm not a statistician, but if you see that much of a gap between these two lines, that's a very significant study. So in my clinical practice in the US, I have also seen very good results, excellent results in some women who had advanced breast cancer, HER2 positive disease, progressed through multiple lines, but taking trastuzumab deruxtecan and had a very significant response and improvement in their lifespan. Again, going to Dr. Pramesh's point, how many people can afford that? One thing I asked around is trastuzumab deruxtecan available in India? And I found that it is available, but one injection costs close to 2 lakhs. And you need to give this injection every 3 weeks as long as the treatment works. So I'm hoping that we can come up with a plan that women who can benefit from this drug are able to get it. So these are some of the targeted agents for HER2 positive breast cancer. And then another mutation is called PIK3CA mutation, and it was found that women who have PIK3CA mutation in their blood have a poor prognosis compared to women who do not. And about 28% of metastatic breast cancer patients did have this PIK3CA mutation. So a drug was developed, a group of drugs. One is called alpelisib, and this SOLAR-1 study showed that if you give alpelisib to women who have PIK3CA mutation, they tend to do better than if you don't get that compared to placebo. And another new drug is called sacituzumab govitecan, which is another antibody drug conjugate. It was studied both in the metastatic and metastatic triple negative setting as well as in the hormone receptor positive setting, and was found to be beneficial. Moving forward to another targeted agent, there is a subset of women who have this mutation called the BRCA mutation or BRCA mutation, which is genetic, and women who have genetic BRCA mutation, they benefit from this group of drugs called PARP inhibitors, and one such drug is called olaparib. And if you give metastatic breast cancer patients who have triple negative and BRCA mutation, it seems to work better than chemotherapy in some cases. Last but not least is immunotherapy. We have probably heard a lot about immunotherapy from the media. In a nutshell, immunotherapy is a group of medicine which can stimulate your own immune systems to fight cancer cells. Normally, our immune system plays a significant role in reducing cancer cells in our body. So when somebody has cancer, if you can stimulate their immune system to fight the cancer cells, it can be beneficial. Studies have found that several cancers, especially lung cancer, head and neck cancer, immunotherapy agents can sometimes do wonders in the right patient. So it hasn't had a major role in breast cancer. Only 2 indications at present. One is in metastatic breast cancer patients who have this marker called PD-L1. If you combine immunotherapy to chemotherapy, it seems to be better than chemotherapy alone. And most recently, women who have triple negative breast cancer, and if you are in a higher stage, if you give immunotherapy as part of the chemotherapy treatment for neoadjuvant therapy, it seems to work better compared to chemotherapy alone, and they were found to have a better outcome. So the take-home points today is that not all breast cancers are alike. Stage by stage, prognosis can vary based on the hormone receptor status, HER2 positivity, and several mutational status and genomic alterations. And treatment is tailored towards each individual. One question we always hear is that, so-and-so had the same stage of breast cancer. She did not need chemo. Why am I getting chemo? The answer to that is no 2 cancers are alike and not 2 patients are alike. The treatment in the 21st century for breast cancer is tailored towards each individual, and the one-size-fits-all does not apply anymore. I want to thank you and see if you have any questions.
As a member of our esteemed faculty, Madam embodies the spirit of our institution. We are not only fortunate to have had you as a speaker today, but also proud to call you as one of our own. Thank you, ma'am. Now may I request our medical superintendent, Dr. Naveen Pillai, to hand over the memento to Madam. Thank you, sir. Thank you, ma'am.
The last session for the day is a virtual one. The topic being epidemiology and new treatment algorithms for liver cancer in India by Padma Bhushan Dr. Shiv Kumar Saran. To chair the session, I invite Dr. Murli Appukutan. Dr. Murli's contributions to surgical extend beyond our borders. He is the first hepatobiliary surgeon to hold European Board Fellowship degree in surgical oncology, and also he is also alumni of the Institute of Liver and Biliary Sciences, New Delhi. Thank you, sir.
Respected chief guests, dignitaries, colleagues, ladies and gentlemen, thank you for the opportunity. I'm extremely privileged and proud to introduce one of my greatest teachers and mentor, Professor Dr. Shiv Kumar Saran. He is presently the Senior Professor and Head of the Department of Hepatology, Director of the Institute of Liver and Biliary Sciences, which is one of the largest liver universities in the world and of one of the first kind in Asia. He is an adjunct professor in molecular medicine in the Jawaharlal Nehru University, New Delhi, and also an honorary professor in the Jawaharlal Nehru Center for Advanced Research, Scientific Research. In his academic career, spanning for nearly 40 years, after his DM from the prestigious All India Institute of Medical Sciences, New Delhi, he has immensely contributed internationally to the field of liver diseases. His approach for the primary prevention of variceal bleeding by band ligation has become the standard of care worldwide. And his contribution for the gastric varices, holding his name in the classification, Sarin's classification of gastric varices, are universally followed. He has more than 440 international publications to his credit, including the New England Journal of Medicine, Lancet, Annals of Internal Medicine, Gastroenterology and Hepatology. His deep interest in physiology has recently resulted in the development of a unique model of endotoxemia, induced portal hypertension in liver disease. And two liver disease he has been described, that is portal biliopathy in non-cirrhotic portal hypertension and acute and chronic liver failure, ACLF, and he is the man behind the APASL guidelines for the ACLF. He has edited 11 books on liver disease, which are the standard references for liver diseases, and contributed more than 69 chapters in various medical textbooks. He is the founding chief editor of the prestigious journal Hepatology International and has served editorial assignments in most prestigious journals in the specialized fields. He is credited globally to give a huge number of relevant and new protocols for the management of patients with hepatitis and cirrhosis of the liver and its complications. His contributions in the field of liver regeneration using growth factors and liver failure, everything has provided options for a transplant-free survival. He has developed 17 major treatment guidelines, including the spearheading 5 major Asian Pacific treatment guidelines in the liver diseases, which are widely quoted and practiced. He is instrumental in the nomenclature of hepatitis B carrier to chronic HPV infection. And he is the person behind showing the mother-baby transmission is the major route of transmission of hepatitis B in India. And he is credited with the help of the governments of Delhi and Sikkim for the launching the hepatitis B vaccination program in India. And he is also the man behind the Yellow Ribbon campaign, which is one of the biggest public awareness program. He is a great academic clinician with research interest, and he has trained more than 90 postdoctoral students in the field of gastroenterology and hepatology, and more than 24 students as a grade of Doctor of Philosophy, PhD courses in basic sciences. Because of that, he has been appointed as an adjunct professor at the Specialized Center for Molecular Medicine at JNU and Jawaharlal Nehru Center for Advanced Research, Bangalore. And he led the Medical Council of India in 2010-2021 and has brought the Vision 2015. He has shown leadership roles in the president of ISG, APASL, INASL, and he is the person to set up the first APASL School of Hepatology in New Delhi. He has been bestowed with the Padma Bhushan by the Government of India and is a fellow of National Academy of Medical Sciences and also presently the president of National Academy of Medical Sciences. He is the recipient of several awards: Shanti Swarup Bhatnagar Award, Third World Academy of Medical Sciences Award, Dhanvantri Medical Award, WHO Fellowship at the University of Freiburg and at Albert Einstein Institute. So many awards and orations on his name. His humility and touch with the common man, integrity, far-reaching contribution to the health and well-being of his patients have indeed left an indelible impact on the well-being of millions of people in the country. His latest contribution is a book, On Your Body, he has written, A Doctor's Life-Saving Tips. And with this, I welcome you, sir, and the podium is for you, sir. Thank you.
Thank you very much for your kind words, Murali, and thanks Dr. Pillai and the organizers, and greetings for this new initiative of the Dr. K.M. Cherian Institute, and greetings on international conference and advances in oncology. I wish I was there, but could not due to personal reasons. I would like to share some of my thoughts in liver cancer area. LBS is a deemed to be university, probably the only liver university globally, and is a WHO center. Liver cancer is one of our main forte. I have nothing to disclose except our residents are smarter. Briefly, the burden and the changing epidemiology. So India is still amongst all the countries in the world is about 2 to 3 or 5% of the liver cancer age standardized incidence rate, lower than China. The burden of liver related deaths is increasing, and now it is believed that about 6.8 per 100,000 males or 5.8 per 100,000 females may develop liver cancer. Arunachal Pradesh is amongst the highest. In fact, Arunachal has highest incidence of liver cancer in the world as per ICMR. The changing trend of liver cancer as projected of cancer tomorrow, highest estimates for liver cancer in the world would be China, followed by India and then rest of the world. This is scary, and India may become a hub of liver cancers. This is the data which was based on up to 2015, and this shows that hepatitis B and C were the major causes. But even at that time, nearly 30% of the liver cancers were either due to NAFLD or because of alcohol. The 2021 paper shows that of all cancers, let's say 100, the commonest cause is NAFLD, and in India, 35 to 40% of the liver cancers are due to NAFLD. This is our WHO Center's recent data of about 2,600 liver cancers. 39.5% were in diabetics or with fatty liver, and alcohol also has made 14% of the liver cancer total. Why NAFLD is more common in Asians and liver cancer is more common in them in Asia? Indians or Asians have more of visceral fat and central obesity. They have anti-HB code. About 20% of the people have this hepatitis B marker positive. They have higher LDL and lower HDL, also hypertension, and PNPLA3, which is a marker, which is a gene, the protein produced by this gene causes lipolysis. So PNPLA3 is present in a very large, in fact about 30% of the population in India, this mutation. TM6, MBOD, the glucose kinase, all these make the Indians populations as risky. And then there is an increased amount of leptin, and due to lack of exercise, decreased adiponectin and diabetes. Patients who have got NAFLD and HCC have a different metabotype and different microbiome. There is a dysbiosis, the gut is leaky, there are immunotherapy is less responsive in them, there is a immunosuppression with higher Tregs and lower antigen presenting cells and CD8s. This makes the Asians and those who have NAFLD much more risky. This is a very interesting study. Non-NAFLD controls, NAFLD with cirrhosis and NAFLD with HCC. And you find that patients who have got HCC, they have much higher proportion of varicomicrobia, and the proportion of proteobacteria, which includes E. coli, as much larger. When you look at these three in greater details at the species level, Bacteroidetes, the red is HCC and NAFLD, the Veillonella, the Clostridium, the Bacteroidetes and Ruminococcus, all these show you a distinct microbiome of patients with HCC and NAFLD. We therefore need to be careful about our diet and the way we are doing our lifestyle dysregulation. What is the level of awareness about NAFLD and not to talk of about HCC at all. The awareness about NAFLD is in about 1 or 2% of the general population, while awareness about hepatitis C could be in a larger proportion and hepatitis B in a larger proportion. Europe has seen a significant change. Alcohol has become one of the commonest causes of liver cancer deaths. In fact, in the Europe, those with more than 50% or 40 to 50%, alcohol as a cause is a leading worry. And this can also happen to India. NAFLD plus alcohol, what you can call as a metabolic and alcohol combination, this could become deadly for us. How does alcohol cause HCC? Very briefly, directly by the acetaldehyde which is produced, and this can lead to lipid peroxidations, production of 4-HNE, adducts, and the repair of DNA is poor and damage is more of reactive oxygen species. Besides that, alcohol directly can decrease sirtuins, which are your regenerative proteins. Inflammation is increased and lipid accumulation increases. So alcohol, which is so common now in our younger generations, can add to the metabolic traits that Indians do already have. The new biomarkers. The standard biomarker alpha-fetoprotein. Now in India we all are using the protein induced in vitamin K absence, PIVKA, or desgamma carboxyprothrombin. This is a marker. A combination of these two is very good, but several new markers have become available which we use at ILBS: glypican-3, AFP-L3, lectin-3, Golgi protein 73, GP73, alpha-1 fucosidase, and MIR-122. None of them actually is a standard marker as yet. But what is important is to know that these can be very helpful, very high specificity of GCP3. Let me show you the sensitivity and specificity. First, AFP can be normal in 40% or so. And similarly, desgamma can be normal in about half of the patients. On the other hand, GP73 can be positive, and therefore this has to be understood that we may miss 40% of the patients. However, these markers are fairly specific. Today, I would recommend AFP, DCP, L3, and maybe glypican-3 as a combination of these 4 markers. Combine them if you have a suspicion of tumor in a patient. GCP, AFP, L3 and DCP are very helpful in predicting, the surgeons would love it, recurrence of liver cancer after transplants. If a person has these markers pre-transplant high, AFP, L3 more than 15% and DCP high, then this patient will have a higher chance of developing a recurrence. You may therefore try and do a local ablative therapy, bring these markers to lower levels before you take up these patients for transplant. Otherwise, in 3 years, there would be a recurrence of the tumor. The next new area, very hot area, is on therapy biomarkers. You have started sorafenib or lenvatinib, but you do not know whether your patient is undergoing a change. The stage change, is it occurring? So new marker angiopoietin 2 can tell you if the levels are high, that best response time to progressive disease, angiopoietin 2 levels will go up, and so will be the hepatocyte growth factor. So rising HGF for angiopoietin 2 can warn you. Similarly, when a combination therapy, to which I will come, the first line therapy is atezolizumab and bevacizumab. A patient is on this combo. Is the patient responding after the second or the third dose? So at 6 weeks, you do EVEGF. If the VEGF level has gone to less than 97 or is above 97, you can say, well, my patient is responding, or do I need an early change to a second line therapy? Baseline VEGF does not help, but on therapy 6 weeks is very helpful. What are our risk factors and protocols for surveillance? Well, a new score called GALAD score is helpful in picking up patients for HCC much more specific than any other score described. There are many other scores. I am not going into details for these. Now, what is GALAD score? It is gender, age, AFP, AFP-L3 plus DCPA, combination of all these in a patient with NAFLD can help detect HCC 1.5 years before actual development. Let's say you have a cirrhosis, you have a diabetes, and you are worried whether he will develop. So every 6 months you keep doing AFP or a CT or an MRI. Simply do a GALAD score and you may be lucky enough to pick up this patient much more earlier, and it has a sensitivity, specificity of more than 90% or so. I recommend this to be strongly used. Now, what modifications we can do as far as surveillance strategies and chemo prevention strategies so that the patient doesn't develop. So an NAFLD patient, you of course will have to tell him to lose weight, add exercise, change diet, coffee, alcohol, abstinence, and smoking. Smoking is also extremely important as much as alcohol because it increases TNF alpha levels to same levels as with alcohol abuse. And well, we have to do further prevention by giving pre or probiotics. The benefits of aspirin, statins, metformin, PIO are very well known, not with obito or immunotherapy. Other modifiable risk factors could be gut dysbiosis, as I said. What we cannot change is age, gender, or the genetic predisposition. A lot of work is being done, including at our place, on the role of carrot exosomes, butter, desi ghee, and of course millets. I would strongly recommend everyone to work more on the Indian traditional diets, which is probably better than a Mediterranean diet, and of course the use of these drugs. So these are modifiable factors. So when you are doing surveillance, you also do a brainwash of these people. What about alcohol? Those who are doing alcohol use disorders and are drinking alcohol and have alcoholic liver disease, the risk factors are age above 55, platelets above, less than 125,000. These patients, if they are male, have a higher risk. If their baseline AFP is above 8, higher risk, and bilirubin score above 2 is also a high risk. And if you have one factor, 2 factors, then the risk of liver cancer, let's say he is 60 years, he is a male, the risk is 4.8%, and then this keeps on adding. So I would say alcohol and obese and elderly should be carefully watched. What are our new treatment algorithms? This is everyone uses the Barcelona liver cancer clinic staging score. This is 2022 modified. I want to go over it slowly and tell you. So based on the tumor burden, the liver function, that is cirrhosis stage, and the performance status, we have used this scoring system. Now it is refined by AFP, by the albumin, bilirubin score, Child-Pugh, and MED. So very early stage is less than or equal to 2 centimeters, good performance status. Well, you can straight away do a resection in them, and resection is as good, but you can also do a liver transplant in them. But resection and transplant will give you equal survival. Early stage A, this is a single or 3 or less nodules. Each nodule is less than 3 centimeters or equal with good liver and performance status is 0. Such patients can have a liver transplant or a ablation by modalities like TACE or TARE, and these patients also, if there is a feasibility, can do resection. Intermediate stage, these are patients which are difficult and there are no clear guidelines. Patients are multinodular, they have good liver functions, good performance status. You can do an extended liver transplant, 6.5 centimeter tumor burdens, but AFP above 400 avoid. You do it, patient may have good survival. If there are well-defined nodules with good arterial flow and a good portal flow, you can do a trans-arterial chemoembolization. The new kid is B-TACE, the balloon occluded TACE, which is far superior. Then, if there is a diffuse or infiltrative or extensive disease, such patients would require immunotherapy. Advanced stage, there is a portal invasion or extrahepatic spread, and the liver function is still okay, not very good, but performance stage is bad. All these patients would require a systemic therapy. This group and this group. And terminal stage, stage D, I think with a poor performance and liver function, the best supportive care remains. Then you have the first line therapy with atezolizumab and bevacizumab or durvalumab or tremelimumab. This combination, one or two, can successfully help in downstage. I will only be discussing one of these therapies. The time for the second combination therapy is limited, but one can go and read the Himalayan trial, which is also published in New England Journal of Medicine. I would strongly recommend that radioembolization has come up in a big way, and lesions as big as 8 or 10 centimeters can be done a radiation surgery. Now, first line was our TKI, sorafenib and lenvatinib. How can you find out my patient on lenvatinib has developed resistance? So lenvatinib resistance can be picked up again, as I said earlier, by angiopoietin 2 or a hepatocyte growth factor rise. Let me go now to the immune checkpoint inhibitors. You can give it as a monotherapy, first line. First line means patient has not received the tyrosine kinase inhibitors, he goes straight to ICI. Or after tyrosine kinase or other therapies, then he gets ICI or a combination. So this landmark study, the Imbrave study, a combination of atezoli plus bevacizumab, in simple terms A plus B, in unresectable hepatocellular carcinoma was given. As you would see here, the overall survival at 6 months was significantly higher as compared to sorafenib patients, number one. Number two, progression-free survival was 54% compared to 37%. But still half your patients do progress. The quality of life and the median time to deterioration, atezoli plus beva gave 11.2 months compared to sorafenib. I think it's a significant advantage, and the hazard ratio was reduced to 0.6. This has now become the first line therapy. It is expensive, and the second durvalumab combinations are much more expensive. But yes, Indians need to develop these biologicals at home. As I showed you earlier, one more time, the VEGF levels at 6 weeks can help you to tailor your patient into another modality of therapy. This has not been published. This is from a Japanese friend, which has shown very good on-treatment biomarker response. Now, this is also not a published data from a Japanese colleague. If the patient has received for the first time straight atezolizumab and bevacizumab compared to after another therapy, there is a distinct benefit. First time, The 8.1 months compared to late as a progression-free survival, no disease progress, and overall survival is superior than when you add after the other therapy. But of course, lenvatinib is cheaper, sorafenib is much cheaper. We all would like first to be treating our patients with those modalities. Can you improve the performance of immune checkpoint inhibitors? Yes, either by local ablation, let's say by RFA or microwave, by giving anti-angiogenic like bevacizumab, stimulation like we are doing with SBRT, or many other methods of stimulating so that your antigen presenting cells become more active and are identified by T cells. This is one more time to show you when a radiotherapy is given, the antigens are released by hepatocytes, picked up by APCs, and they are presented to T cells. So this is a very good method, and the abscopal response in the distant tumor also occurs where the tumor suppresses because of the cytokines released from the tumor. The second part is APCs improved. Your APCs can activate T cells. You can add here the ICIs, and this is a good idea. You can also improve the trafficking of T cells and break down the tumor microenvironment, and the T cells can get inside into that. This is the concept of a hot tumor versus a cold tumor. A hot tumor is where you have stromal and tumor infiltrating lymphocytes are more than 60% or so. But these cells get into your T cells, get inside into the tumor, and they are actually able to kill. But in a cold tumor, they are not able to get inside the cells. So the intermediate varieties are 10 to 16%, and in a cold tumor, stromal TILs are 0 to 10%. Our aim is to improve and change a cold to a hot tumor. Asians have a habit of being aggressive, more so in patients where HCC is being treated. Asian centers have a special ability. Their resections, they go up to 10 centimeters, 15 centimeters, even with lower body mass index. They transplant more. The regional therapy levels and systemic therapy levels, especially with concomitant B and C, are being given. So Asians also take up larger tumors, multifocal tumors, but we must remember the response to sorafenib is less, and response to immune checkpoint inhibitors in NAFLD in Asia is less. This is a very interesting slide which I borrowed from my Japanese colleague. Here is a patient who has an advanced invasive HCC. He was given atezolizumab, and it became a complete response which was durable. This patient also had a VP4, means the whole portal vein and the branches were there, they could be made cancer free. And this patient was not at all a candidate for surgery, but he became borderline resectable, and a conversion surgery was conducted in him. I am sure we are following the model of lung cancer or breast cancer and others, and liver cancer, if the bulk can be reduced either by radiation or by surgery, I think it is a very useful therapy. With these, I would like that the algorithms, the surveillance programs, and the risk factor assessments must be jointly done, and especially some institutes where organ-specific institutes may be included. ILBS sees close to 1100 liver cancers in a year, and we would be very happy. I missed the morning talk of the cancer grid, but if any other mechanism, we will be more than happy to be included into the programs. I would like to say, don't say no time for liver, say I have time for my liver, protect it. And this is my last slide to give you a carry home message on therapies and new management protocols. It is clear that patients who have got advanced stage C, with portal invasion or extramural spread need systemic therapy. Those who have got diffuse infiltrative lesions need systemic therapy, and these patients can live for more than 2 years today if we work hard with our first line or second line therapies. If these are not available, TKIs can be given, and we can add in those where there is resistant cabozantinib or ramucirumab, especially with bevacizumab problems. We can add these drugs. We have to convert the cold tumors to hot tumors, make them immune active, and combinations today of immune checkpoint inhibitors, anti-angiogenic therapies, with or without SBRT or TKI. So triple therapies are now very popular. We use it regularly. Or you do the stereotactic radiotherapy, and then patient can go for liver transplant or TACE, TKI and liver transplant. Our challenge remains for patients post-transplant HCC recurrence. We have no good therapies for them, but we do hope in near future we will have. I have tried to present to you snippets of advances in every small field for HCC, and I do hope that we would be able to work together with the institute that you have starting today, and thank you for your kind attention.
Thank you, sir. Hence, we come to the end of the scientific sessions. We have had the privilege of hearing from esteemed speakers who shared their expertise on various aspects of oncology and palliative care. Before we conclude, I would like to invite Dr. Sara Isho for giving the vote of thanks to express our collective gratitude.
I'm the one thing that's holding you back from a delicious lunch, so I promise you I'm not going to keep you long. I will make it short and sweet. So today is World Cancer Day, and we are so thankful that the inaugural meeting of our cancer center happened with the presence of such esteemed guests who are great pioneers and who has done great work among cancer patients. The theme for World Cancer Day is Close the Care Gap. All of our guests today have dedicated their lives to closing the gap in cancer care locally and globally. Their vision and commitment to eliminate the disparities in cancer care in various fields have already made this world a better place. Dr. C.S. Pramesh has traveled quite a long distance to be with us today. We couldn't have found a better person to inaugurate our cancer center other than Dr. Pramesh. His dedication to the National Cancer Grid has brought together cancer centers across the nation with a common goal. We are happy and privileged to have an opportunity to join the National Cancer Grid in the future. On behalf of KM Cherian Institute of Medical Sciences and the Oncology Center and this audience, I extend our gratitude to Dr. Pramesh. We just heard from Dr. Sarin, the world-famous liver specialist, who has given us a detailed talk about liver cancer. Though he was unable to be with us in person, he has been listening and he's been our well-wisher. We extend our gratitude to you, sir. Padma Shri Dr. M.R. Rajagopal, sir, is known as the father of palliative care in India. He is the reason for making the word palliative care so familiar in Kerala and in many parts of India. We are so honored that Dr. Rajagopal sir was able to come today and bless us with his presence and a great oration and gave us all a wake-up call about our own mortality and our own death. Dear sir, please accept our sincere gratitude and we hope to work with you soon. The person behind it all, the mastermind that made this day happen, is none other than our very own advisory board chairman, Dr. M.V. Pillai. He is known to us, his friends, as Ashayangal de Ashan, and his ideas have blossomed into very successful projects in the US and in Kerala. Let's hope and pray that this dream project of his will be successful as successful as and useful for humanity as his other projects. We extend our gratitude to Dr. M.V. Pillai. Our chairman, Mr. P.M. Sebastian, was not able to be with us here physically, but he is watching us and he is blessing us this event from far. This cancer center is actually dedicated to his name, to his Saptadi. Thank you, Mr. Chairman, for giving us this opportunity to come together as a team and begin this work. We extend our gratitude to Mrs. Sebastian and Vice Chairman Sibin Sebastian for his talk. So I joined this hospital only a month ago, and I've seen that the staff here is unique, and I'm amazed by how well the staff works together. Everybody, from doctors to nurses to the marketing team and the hospitality team, everybody goes out of their way to work together, well coordinated and well disciplined. And I know the person behind this all is none other than our managing director, Reverend Father Alexander Kudarathil, and I give our hearty thanks to our Achan for being the person behind it all. And he cannot work by himself. And there's another person whose name was not mentioned here, but I've seen him walking around this podium many times. The tall guy with the white shirt, Mr. Sebi Paulus, our COO. He has really made this day happen, and I really extend our hearty gratitude towards Mr. Sebi Paulus. Many other people work together to make this happen. Our MCs. Please stand up. Dr. Pooja and Dr. Arun, you've made a great job today, a great job. All the team from the oncology department, Dr. John, Dr. Murli Appakutan, and all the other doctors who've spent the whole day here. I know this is your one day to take rest, but our cardiologists, our internal medicine doctors, and all the specialists are all here to attend this inauguration of the Oncology Center. I really appreciate all of you for being here today. And our hospital, many different teams, a marketing team, Nebu and his team has been working so hard to make this event public and to make everybody aware about it. And the audio visual team for making these beautiful slides and presenting it on stage. Our stage coordinators for the beautiful stage. And our food team for providing great food. And most of all, I thank all of you for coming here from near and far. Some of you have traveled from the US to be here. My friends, please, I accept my gratitude for coming here, and all of my classmates who are here today, and everybody else who joined this meeting today to make this a great success. If I forgot everybody's name, please forgive me. This is my first time. Won't happen again. Thank you.
Thank you, ma'am. Once again, thank you all for being part of ICON 2024. Lunch has been arranged in the ground floor canteen for the delegates. Following the national anthem, request all dignitaries to take the escalator and proceed to the second floor for ribbon cutting ceremony marking the inauguration of Oncology Center OPD and the chemotherapy suite. Safe travels, and we look forward to seeing you again at future events. Request everyone to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे